Good morning. Welcome, everyone. Thank you so much for joining our webinar on federal research investments in whole child health and well-being. I'm Diana Fishbein, otherwise known as Denny. I'm very excited about our agenda today. We have numerous outstanding speakers and very important content that we hope will drive the public and policy narrative on what children need to be healthy, to have well-being, and flourish for a lifetime. I want to kick this off right on time. I know people are still entering the platform, but we have an awful lot to pack into our day. These are our sponsors. I'll just quickly read the National Prevention Science Coalition to Improve Lives and the Child and Adolescent Health Measurement Initiative are main sponsors, the Decade of the Child Committee, the Nova Institute for Health, the Edna Bennett Pierce Prevention Research Center at Penn State, and the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. So to make the most out of this webinar, please do feel free to engage in the chat, develop a sense of community, but know that the speakers will not see questions that you have unless you enter them into the Q&A. So please do that. And a recording and resources will be available in about 2 weeks. Now I'm going to ask you all if you would please complete this poll. We'd really like to know what sector each of you represent, and you should be able to see this on your screen. I know we don't have everybody here, but we will try and get these numbers together fairly quickly and see what kinds of sectors we have and the diverse perspectives that are here today in our audience. And everyone can see we've got a lot of researchers, healthcare, education, some mental health, philanthropy, activism, and let's see, we've got government, some policymakers, some nonprofits. So I'm going to stop sharing, but please do continue to share in the chat. And we will look at those results later. Okay, so I'm going to open with a framing for bench to trench. This is going to set the through line through the Decade of the Child initiative, which is really about translating the scientific evidence into lasting public benefit. The Decade of the Child initiative is a framework and an action plan to move our most rigorous developmental science out of journals and into the everyday environments where children actually grow up. So everything that follows this initial talk will show how we can close that distance. The process of moving knowledge from science to practice and policy, as we know, is very protracted. So we developed this framework that was published back in 2016, specifically for prevention science, a 40-year-old, very rigorous discipline, but it can apply to any science. But we wanted to facilitate the translational translational process and ensure that the programs and the practices and the policies that are generated are actually based in scientific evidence with greater potential to affect the phenomena that we intend to prevent. And in this case, that will foster conditions that nurture whole child health and well-being. So it's critical that at each stage of research, we think to the next stage of translation to make that research actionable and have greater utility. So to effectuate that aim, about 13 years ago, I started the first organization in the United States to translate knowledge and best practices that have been amassed from the prevention sciences into public health policy. And that is the National Prevention Science Coalition to Improve Lives. We know so much, but those who stand to benefit the most do not. So as an organization, we work at the federal level to inform legislators and agency officials about prevention science and its relevance to public policy. And we also work with states and local communities to encourage adoption of evidence-based preventative measures. As I said, the science has come so far. We have made extraordinary advances in behavioral, developmental, social, biological, brain sciences, etc. But in truth, the outcomes for many children have barely budged, which is what is showing here in this slide, the contrast. And so, despite the decades of progress in what we know, children are still facing intersecting risks, physical risks, mental, social, relational, and developmental. So, the gap between the scientific maturity and the lived reality is the problem that we're here to solve. The home, school, and community overlap. They are the actual ecology of a child's life. I want to note that this figure leaves out the critical role of societal structures and systems, as well as public attitudes and mindsets that are equally as impactful. So considering all of that, this ecological reality makes it clear that the risks to children's health rarely arrive one at a time. They tend to cluster across settings and compound over time. And that clustering is exactly what fundamentally shapes a child's capacity for learning and their long-term trajectory for opportunity, which is why basically isolated single interventions keep falling short. These curves show how early experiences set really divergent pathways. So another contrast here is between the protective uplifts that children are exposed to, like in good education and healthcare and economic well-being, contrasting with adversity anchors that they might be experiencing that can weigh them down, that can stall their development. So intervening early, or as I like to say, better yet, designing supportive infrastructures, reducing environmental and social harms, and informing the public and policymakers about what children need to thrive together so it does not temporarily lift a child above this baseline. It actually bends the trajectory for a lifetime. Without these protective uplifts, adversity becomes an anchor that can compromise trajectories across the life course. So the central call to action is to move to the next translational phase. The next frontier is no longer only generating evidence, although we still need to do that, obviously. But what we're focusing on here is deploying the evidence, moving from discovery to wide-scale implementation and broad policy solutions. The challenge is to translate practical and scalable evidence-informed practices into strategies that schools and health systems and families and communities can actually use. And that's what I mean by trench. So there are three landmarks that we want to reach: knowledge generation, the chasm of isolated success, and lasting public benefit. At present, the potential for impact isn't reached because it devolves in these messy real-world settings. And too much of our field's work crosses the first bridge and then it stalls in this chasm. So, for example, the knowledge that remains hidden, or pilot programs that work but they never scale. So today's question is, how can we build that second bridge so children actually receive support at the population level? Oops. No. Go to my next slide, please. Turn mouse. Okay. Oh, I'm sorry. Wow. Okay, that requires a paradigm shift in research priorities. And that shift involves a greater emphasis on pragmatic research and not only traditional research. Again, that is still needed. So the rows here reflect how such research is conducted, the environment in which it takes place, the aims or the focus, the duration of studies, and the primary measures of success. Traditional research thrives in ideal controlled conditions with short time frames and statistical significance as the bar. But pragmatic research moves into diverse real-world systems. It prioritizes adaptation and dissemination. It takes a long-term sustainability view, and it measures the complexities that lead to lasting public benefit. This is the anatomy of pragmatic research, and this is the decade of the child's. It's one of our two main aims. These are the four operational pillars at the heart of this pragmatic program of research: implementation, dissemination, scaling, and sustainability. And it's this engine, if you will, that fosters whole child health and well-being through applied science. And each pillar is a discipline in its own right, but we want to hold the four together rather than treating them as sequential. So in this way, it represents a pathway from lab to life. There's no single institution or discipline that can address these challenges alone. It's very clear that we need cross-sector alignment for labs and schools and clinics and families and funders to move together so that insight at the lab bench actually becomes a better life for a child. Progress then depends on how we align these sectors around a shared goal, supporting children and families in coordinated, developmentally informed, and equitable ways, as you can see in this figure, that lines up research, practice, and policy and community in one direction. And if one gear turns in isolation, the system fails to advance. So this hub, which is centralized around the whole child, underscores the integration story. Today's pathway to action is sequenced from the evidence-based to federal investments in systems transformation, and our speakers will guide us from that foundational evidence to concrete policy levers. If we invest in what matters most, in whole child health research, implementation, cross-sector collaboration, and policy, we can deliver more than any single program can. And the return is concrete, as I show here on the right, where every child has the opportunity to flourish. So this background basically lays the foundation and the rationale for the Decade of the Child initiative, which is to foster a whole child health approach and comprehensively address these prevailing and interconnected risk factors that are stunting growth and impeding a child's ability to flourish. It's preventative, it's upstream, it's developmental, it's health promotive and holistic. And it also, second aim is to inform a policy blueprint. And these are our 4 prongs. So I'm pleased to very quickly announce that the governor of our state, Josh Stein, has proclaimed this the Whole Child Health and Wellbeing Month, the month of June, on behalf of the Decade of the Child in response to the proclamation that I wrote. I'm going to quickly mention this congressional briefing, but I will mention it again later because we don't have time now to get into it, but please make note and we'll put it in the chat. Our co-moderator today is Maddie Japina. She's a family communication researcher in communication arts and sciences at Penn State. Behind the scenes, we also have Dr. Holly Chapman at the University of Texas, who's going to be helping us with the platform. And all my heart and gratitude goes to Jess Stavig, our strategic director, development director, who provided invaluable support. So I'm going to turn you over to Maddie, who will introduce the speakers.
Thank you so much for that introduction. I am going to begin by introducing our first speaker, Dr. Christina Bethel. Dr. Bethel is the director of the Child and Adolescent Health Measurement Initiative and a professor in population, family, and reproductive health in the School of Medicine at Johns Hopkins University. Dr. Bethel is also a co-lead of the Decade of the Child Committee. And while Dr. Bethel sets up, I'd just like to remind everyone that people's full bios are linked on the NPSC website if you'd like to learn more about them.
Thank you, Maddie. And with Denny and many others, I am so honored to be here today to provide a United States profile of child and youth health and well-being, and to start to deepen the dialogue around the science-driven possibilities to improve early and lifelong flourishing through this decade of the child and all of our collective efforts, which have been going on for so long. Just briefly, the Child and Adolescent Health Measurement Initiative, based out of Johns Hopkins University, has been on the journey since 1996 with all federal, state, and local. We do run the National Data Center for Child and Adolescent Health, which, if you want some of the data at the state level that I'm going to be presenting to you today, a fair amount is available there. And we're joining you and everyone with the goal to really define what our ultimate North Stars are for population, child health, and well-being, to discern and develop the evidence, the research, the data, the tools, the models, which we have a lot of now, and ultimately, like Denny said, to inform all those transformational partnerships that have to happen at the county, city, neighborhood, and state levels, and federally, to really innovate and act and continuously improve. So that's what we're up to and what I've been up to for a long, long time. I don't have any financial relationships or disclosures, but I always like to say that I am biased and that I really do believe that we have enough science, a lot of consensus, and unprecedented opportunities to translate the science of healthy development. So I want to take a pause. I'm going to be showing you data, and a lot of this is so you could even look at it later. Maybe we can get you more detailed data, but right now it's a journey. So I'm going to take you through it. So we know Americans care about their children, yet still 80% are 80% more likely to die than European countries. Sorry about that. Hang on. The United States ranks lowest, I think most of us know, out of many other industrialized countries for childhood morbidity as well, in addition to mortality across a range of issues. And most recently, 36 out of 38 industrialized countries among rich countries. And then the most recent Child Wellbeing Dashboard, has many indicators in it, but one that's very striking, and I think that we all see, is that only 31% of 15-year-olds today are reporting high satisfaction with their life, and there's a lot more underneath that that's available to share. And then in terms of our population and adult health, the science is very clear that lifelong health starts in childhoods, that, obese children are 5 times more likely to be obese in adulthood. 90% of adults with a substance use started in early in adolescence. Half of lifetime cases of mental health, emotional behavioral disorders start by 14, 3/4 by 24. And of course, adverse childhood experiences are associated in biologically, developmentally possible ways to explain over and over, leads to lower education, productivity, and early death and disease and morbidity, costing the country a lot through the diseases of despair. And then, of course, we also know that school readiness and engagement is essential to economic well-being, is strongly associated with lifelong well-being and flourishing. And all of these are threatened in the United States and have been for some time. This is just a graph showing the most recent prevalence of children 0 to 17 who currently experience chronic or lifelong conditions that are assessed through the NSCH, which is going to capture most of the kids because there's so much comorbidity, even though we don't measure every single condition because of low sample. But half of these children have more than one. So we have a lot of comorbidity. So 40%, almost 41, having a condition. And here's the cross-cutting across types. But the comorbidity is very high. There are almost no kids with asthma who only have asthma, literally virtually no children with depression who only have depression. So this gets more toward the need for a holistic, integrated, even medical system, right? But we have all the evidence that wide ranges in quality of life and functioning based on social, relational, and quality of care, as Denny said. So, and I'm pointing this out, that the prevalence of some of those conditions that are the most predictive of these diseases of despair in adults are on the rise: depression, drug use and overdose, and obesity. So as Denny said, we have lots of different models that can look at the eco-biodevelopmental model. This is from Dr. Garner and team, showing that our ecology actually is driving biology in many ways, from gestation all the way forward and even intergenerationally through the epigenetic chains. And that's driving a lot of health and development. But we have power to do something over that. And as we continue to work on the biological sciences and bring these two together. So we're very excited that we have this. This is a huge milestone, along with validation of many approaches that have been shown to work, decades of work actually at this point to create the national and across state data that allows us to talk about at a population policy level, how are we doing at a subgroup of children and states? And so we have a lot to build in. And in that work, we created something called the Whole Child Risk Index, which I want to show you some results of that I think are pointing to where we need to go. So it took a long time to get all the variables in one place to look at medical conditions and mental health and developmental conditions as it relates to these evidence-based social risk factors that we know: economic hardship, food insecurity, exposure to community violence, things like that, relational health risks, adverse childhood experiences, low parental mental health, and things like that. So we were able to look at how medical health risks are connected to those and split them up so we could understand, if we just solved social risks, would that do the trick for lifting up relational health risks, and so on. And here's what we found. So busy slide, but it's all the states are in it, showing what is the proportion of children in the United States who qualify on one or more of these domains of medical conditions and complex needs, social risks or relational. And it's about 2/3 who do. Most meet two or more of those risks that accumulate together. And about 2/3 of anyone with a medical health risk also have social relational risks. So if we're seeing people in clinical settings and we're not aware of these other things, we're treating the condition without understanding the context that actually could be driving that condition, and certainly will predict what the outcomes of our treatments are. This equals 104, about 104 national malls filled with children, if you like visuals, and school buses filled with children going from Miami all the way up to Anchorage, Alaska. And those visuals can be helpful to help us understand the volume of what we're talking about. But this is one of the things I really wanted to point out that we didn't really know we were going to find, because it was truly a question, are how does social and relational risks fit together? Because we often bundle them together as all social risks. And what we found was that children who had no social risks, in terms of economics and needs met and things like that, but still over 2 times had medical health risks, mental health, physical conditions, chronic conditions, if they had 2 or more of those relational health risks, going up to 70%. And there's many communities in the United States that have children with 2 or more social and relational health risks. And so we know we need to focus on those high risks, but it's also all of us with, 54.4% with relational health risks, which are quite prominent in the United States and are explained very well by our neurobiological sciences on how that impacts health early and across life. So, and it's all of us, again, like I said, that this is another study with the same index, whole child risk index, looking at mental health with 3 times the rate of mental, emotional, behavioral health. If there's 2 or more of these relational health risks like ACEs and other things like that, even without the social risk. So this is just all to say that it's a population-based approach that we need. I am pleased to report one of my professors at University of Chicago, James Heckman, who did win a Nobel Prize, he's a Nobel Prize winning economist, has also made a statement that it's not just all the neighborhood and things like that, but it really does matter, the family. And it's a big question for us how we handle that. But there's a lot of evidence-based practices like brief child-parent psychotherapy showing that it increases epigenetic age among children who've had trauma. Yet these interventions, even when they're paid for, are not being scaled. So some of the most obvious things that we would scale aren't scaled, even when they're paid for. That's also true for developmental screening and really basic things. So the system itself is what's in the way, and also the training and the practical issues that are at play. Part of what's been going on too is in all the research that we're lucky to now do is to really show the variation in how kids do based on similar levels of risk and adversity. that more likely isn't actually always most. You're more likely with ACEs to have a lot of problems, but in some cases, most don't have them. So why? And this is where we really see that the absence of the adversity is not the same thing as well-being or flourishing, and that many children without any risks or illness are not flourishing, and like school readiness, engagement, having capacity to have positive relationships, and the things that really make up our well-being and productivity and happiness in life. So reducing adversity is not enough. We have created also measures of flourishing, which really have gone to flip the narrative, to proactively promote positive health and healing as our North Star, not just the reduction of bad things, but the promotion of good things. And it's really important to do that because it helps explain at a deeper level what's really going on in terms of how our system needs to be organized. It's a dual continuum for sure. I'm sure you all know people who don't have a lot of risk or illness but aren't flourishing, and many people who do, who are. And so that's true for kids. We do measure it. I'm not going to go into the detail, but a lot of people want to know the detail. If you do, we can talk later. But we do have measures of flourishing, and their national outcome measure under the Title V block grant in the country now after decades of working on them. And what we see is that they're very predictive of school engagement, which we all can agree we care about. We know the impact of that for the economy, for well-being of our nation, and for children, that depending on whether they always, usually, or sometimes never meet these indicators, they're much more or less likely to be engaged in school, with dramatic impacts, 18% to 72% for this quality of being able to regulate emotions and behavior. Similar for early childhood with our school readiness measure, which is super exciting that we have, also nationally, also a national outcome measure for Title V, and that these indicators of flourishing are actually more predictive than the negative indicators of ACEs for things like school readiness. So looking at the positive, promoting the positive, even in the midst of the adversity, is something we can all get to now, because a lot of the solutions are relational and contextual and things that we can impact. So this obviously raises a lot of questions at a population level, because we have studies that are smaller populations and things like that. But at a population level, we really wanted to see if it was possible to promote flourishing with high risk, with kids with high risk, and whether it looked like these relational health factors really were having a big impact the way that the science was predicting. So this was basically showing that for family resilience and connection, which is an indicator nationally as well, that across all levels of ACEs, 0 to 4 or more, all levels of poverty, all levels of complexity for chronic conditions, that consistently strong family resilience and parent-child connection are strongly associated with child flourishing, which is in turn a direct shot to school engagement and school success. So this pathway is being clarified, which opens up a lot of opportunities as we continue to address all the other structural elements. So being whole child means being whole family oriented too. And again, that raises a lot of issues. In the Family Resilience and Connection Index, we look at things like, do families feel like they have strengths to draw on? Do they feel helpful in difficult times? Do they stay together and reach out for help when things are hard? And, these may seem ineffable, but they are not ineffable, and they are trainable, and they're things I think we're built for, but often our context doesn't support us. So these are important things to start to make hardcore issues for science, and not just, just sort of assume that they're happening if we solve all the economic problems, which actually does not look like it's the case. Getting to adult health, what's exciting too is, so many of you may have now heard of positive childhood experiences. Now that the familiarity with adverse childhood experiences is very high. But the question that we had and that I had was, can we validate in a dose response way, the same way as ACEs, positive experiences? And what is the nature of those positive experiences? Is it the absence of the negative, or is it the proactive promotion of the positive? And indeed, it's not only the proactive promotion of the positive, it's actually how we are with each other when things are hard. It's a paradox. So how we are in the midst of the adversity to connect, to be a safe place to talk about feelings, to feel safety and stability and nurturance for children in the natural order of life's difficulties is actually a very powerful predictor. And for adults that look back on their life, just like ACEs, those that have more of these at all levels of ACEs are much less likely to have depression, mental health problems, more likely to have their own relational health, and newer research is showing that this is the case across many conditions. Just to give you a number, 72% lower odds of having adult depression, even with 4 PCEs, if you had higher levels of positive experiences, which can occur through any door, schools, community, and in the family as well. So excitingly, a new study, the last study was in JAMA, this one as well, verified that about half of adults are reporting higher positive childhood experiences. Again, with half of kids living in homes with families that report family resilience and connection, and half of adults validating that they have PCEs. It's very important that we see that we've got about half the country that really is struggling in these ways that we can proactively promote. As they say in quality improvement, we can do something by next Tuesday. So, and also the costs, that this was about $216 billion across just 4 states of economic costs, and that would be in the trillions and trillions at the national level. So here we are, as I begin to wind up, that we're at a place where we've learned a lot about what's happened to whom. Why did it happen? What will happen if we do some interventions or things vary? But the real questions are, how can we make it happen? And also, what's working for whom? Because personalization is important. And so how do we create systems that can achieve the possibility for really sustaining implementation, as well as being personalized and dynamic? And we actually have a lot of evidence that this is possible in pockets, but not at a population level that's really going to move the dial for policy and spread. The good news is we have a lot to build on for the whole person movement, whole person health movement in adults, which is very embraced nationally. Principles, and there was Achieving Whole Health report in 2023, 2024, as well as the NIH did a cross-institute, cross-agency effort to create the whole whole person health index for adults, but we don't have it for kids. I shared with you our whole child risk index, but that's a quick win. Recognizing the very same things I'm talking about here: chronic stress, of course, diet, food, fun, fitness, these are key things, but chronic stress and all the strategies there. And interestingly, they also found the highest correlation among the domains they measured were between social and family connectedness and quality of life. And then quality of life was a hit for health. So when you look deeply, even at this index, it's also showing and pointing to some of the same things that we need to address. So that's an example. I think we're ready to soar. And we've started in 1967 with EPSDT. Major breakthrough, updated guidance is awesome. Very supportive of everything we're talking about, including systems change. We've had Bright Futures national guidelines for prevention, the decade of the brain, which we're going to talk more about what that was, the neurons to neighborhoods, which was a direct out picturing. So a decade of the brain had a lot of power in sparking things, kind of slowly, but it did. And we've had more recent roadmaps, like the Launching Lifelong Health is a 10-year roadmap for, really improving systems, defining healthcare systems to include schools, to include community-based, because like Denny said, we have to do this together. So there's a lot to draw on, and common elements across, I looked at 25 different recommendations and reports that are out there and emerging, and there's so many now, which is exciting. I would say child flourishing is our greatest public health opportunity. And the key elements that are across all of the different reports are, of course, importance of leadership and governance, financing, data, implementation structures, and really solving practical barriers for assessing and sharing data and using digital health. And we're way behind on that in pediatrics, as we know in the nation. And then, of course, training, payment, and performance measures. I've looked at all these different accountability systems the America has and really looking inside of them. And the words are there. A lot of the words that would depict, oh, we're doing that. But when you look and unpeel it and look at what's really happening, it's not being implemented. So we have to be careful to not just put down on paper these things, but to really go deep. And it's hard, but we've got a lot of very specific roadmaps that go beyond the elements, but go into how exactly would you do this in these different contexts and with policies and with training and so on and so forth. So we have a lot to draw on. But having gone through the journey, this is just a visual you can look at later. This is a 2016 to 2024 look on things like well child visits. Only about an estimated 45%, 0 to 15, actually have all the 9 visits they're supposed to have. When they do have them, developmental screening usually doesn't happen. Maternal depression screening, very basic things. And then the data can't be shared, right? So we have solutions for that. So you can see here almost no change or a decrease in that time frame, where we've also had a lot of innovation and an agreement, as I just said, about what we need to do. So we have this opportunity. There's a recent 2026 NASM report on NIH funding in pediatrics that I feel compelled to point out, and it's very consistent with what we're talking about, and we're going deeper with that. So we all have to get together, but there's a lot here immediately to work with, recommending some of the same structures that we would recommend, and really helping the nation get together. There's many detailed platforms for research that our follow-up speakers or speakers for the rest of the day are going to speak about, including translating hardcore science like the cell danger response and biobehavioral synchrony into practical clinical approaches, because the science is there, but the bridge is not. But the impact, if we made that bridge, would be enormous, and we need to do that. So that's what I'm going to leave you with. And I thank you for your time today, and look forward to continuing the dialogue. And I'll turn it back over to you, Maddie.
Thank you so much for that presentation. Now that Dr. Bethel has presented the challenges children are facing and defined whole child health, we'll hear from Dr. Zilli Sloboda. Dr. Sloboda is the former division director of the National Institute on Drug Abuse at NIH. She also founded and directed the Applied Prevention Science International, and she inspired the Decade of the Child concept over 20 years ago.
Good morning, everyone. And hello to friends and to new friends. I think Christy, Dr. Bethel, just presented a truly wonderful foundation for our discussion today on building a blueprint for advancing not only the healthy future for our children, but for children around the world. Thank you. We have developed policies and programs to support our natural resources, such as water, minerals, forests, and fossil fuels. But what is the point of all of this without supporting and preserving our most precious resource, our children? The Decade of the Child is an effort to achieve this goal. The Decade of a Child is an effort to move things forward. And I think the National Academy of Sciences that Christy mentioned, their report, Launching Lifelong Health for Improving Health Care for Children, lays the groundwork for this effort. And it seems like there's a lot of stuff going on from what Christy was presenting that needs to be pulled together. The Decade of a Child will provide the structure to launch a health program that will improve the health and well-being of our nation's children. We've heard this already, but I think these observations warrant repeating. The report from the National Academies underscores the long-term consequences if we do nothing for our children. We will see increases in chronic illnesses, early mortality, and health overall. That not only will place a burden on the healthcare system, but on families, communities, and ultimately the economic structure of our nation. The Academy's report recommendations encompasses a systematic approach to alter the current trajectory, including financial reforms, with a focus on preventive care, building a stronger and better integrated infrastructure to support our children, and better epidemiologic data systems to warrant and to monitor health outcomes, which is something precious to me as an epidemiologist. How do we achieve these objectives? We have a successful blueprint to guide us, the Decade of the Brain, that was implemented from 1990 to 2000. And actually, this experience with the Decade of the Brain occurred while I was at the National Institute on Drug Abuse. And it was at that time that my colleague Liz Robertson and I thought of the decade of the child. So this concept goes back a long way. On the next slide. Prior to the initiation of the Decade of Brain, several significant foundational events took place. In 1988, the National Advisory Council of the National Institute of Neurological Disorders and Strokes prepared a report, Decade of the Brain, Answer Through Scientific Research. This report provided concrete evidence that many neurological disorders could be prevented, cured, or alleviated if research opportunities were fully exploited with adequate funding. The following year, the National Advisory Mental Health Council prepared a report, Approaching the 21st Century, Opportunities for NIMH Neuroscience Research. And this report identified 50 important questions to answer in the decade ahead. Based on this report, a congressional resolution was passed that was established to enhance public awareness of the benefits of brain research. It encouraged research and public education, which I think is really important, on brain disorders, neurological diseases such as Alzheimer's and Parkinson's, mental illnesses, and the central nervous system. And that's supported the recognition that the study of the brain involves multidisciplinary efforts of scientists from many areas. And in 1990, President George Bush made a presidential proclamation that established the Decade of the Brain. Following this proclamation, the National Institute of Neurological Disorders and Stroke drew up an implementation plan called the Decade of the Brain. And that's something that we really want to look forward to achieving, putting together such a plan. The initiative sought to increase funding for National Institute of Mental Health, the National Institute of Neurological Disorders and Strokes, and they were to map the brain, develop treatments for neurological disorders, and ultimately to reduce the economic and social costs of brain disease. In addition, and I think this is also important, the Library of Congress partnered with NIMH to host public lectures, congressional briefings, and symposium that tracked progress so that information was disseminated to various sectors of the country. The accomplishments of the Decade of the Brain, next slide, included neuroimaging, was a widespread adoption of fMRIs, which allows scientists to observe brain activity in real time. Genetics, the mapping of specific genes linked to neurological diseases such as Huntington's and Alzheimer's, and then neuropharmacology, the development of targeted psychiatric medications and treatment, all of which led to a reduction in the economic and social costs of brain disease. Next slide. Not only did this have an impact on the United States, but it had a global impact. And it created a global coordination and international brain initiative that led to the creation of research centers around the world. And that I think we all learned a great deal by this international research. And most importantly, it destigmatized mental health issues, which is on the next slide. And this brings us to the decade of, okay, can I have the next slide, please? Okay, so this brings us to the decade of the child. And I think we've heard this morning already from Christy, that health is not a silo, that it's interconnected system requiring holistic interventions from prenatal period through late adolescence in all of these areas. And I like the term that she uses, flourishing, have children who are flourishing. Next slide. So our goal is to prioritize whole health, whole child health, and well-being from prenatal period through late adolescence, including, as you can see, physical health, mental and emotional health, social health, and relational health, which Chrissy was talking about. And I don't think we talk enough about how important that is for our children and for having successful outcomes over time. Next slide. This overall investment in the whole child concept has the potential to protect the future workforce and working parents, improve the health of future mothers by making prenatal and postnatal health care available, addresses early antecedents to adult and chronic health issues, and to leverage the potential of prevention across all communities. And this slide shows okay, sorry, that was kind of the next slide. This is a unified vision to unite public health, education, child welfare, and academic research to develop a unified, science-based roadmap that helps all children thrive. I think the challenge that we have is going to be how to translate all of this to communities across the country. So the blueprint of the Decade of the Child is shaped through both advocacy and policy to secure congressional funding and support the National Institutes of Health to take the lead in this effort. We have the historical precedent now from the Decade of the Brain. We have the mandate. Our children are struggling, and we need to build a healthy and secure future for them and for children around the world. Thank you very much.
Thank you so much. Maddie, I'm just going to interrupt for a second. Zilly, could you go on video for a minute? You weren't on video,
Oh,
just so people can see your beautiful face. There you are.
I'll pay you later.
There's no webinar without a technical glitch, so forgive us, but we're moving through and that was great. Thank you so much. Just so that I can get back to this and just bring this to the fore for a second. This congressional briefing that's being conducted by the lead authors of the National Academy's report, the Launching Lifelong Health report that we've mentioned, and they're having their congressional briefing on July 21st, and are inviting all of you. So if you would like to attend, please RSVP to Charla Ramsey. I hope everybody is thoroughly rested. Welcome back. I'm thrilled to report that attendees have replied from 25 states, Washington, D.C., my hometown, Europe, and Kenya so far. So that's pretty exciting. As for just a few points from this question, some of the things that have come up, the themes, consistent themes that have come across are with respect to barriers, fragmentation of resources, funding and sustainability, lack of coordination, collaboration, and access. Also, the greatest barrier that was called out was systemic forces, poverty, parental mental health, healthcare access, as well as institutional barriers, mindset, inequities, educational reach are not being addressed. Again, some of the very familiar themes we've already referred to in this webinar so far. And so we really appreciate you giving us your perspective on these issues. We'll have a couple more questions at other breaks and during our lunchtime. So, Maddie, I'm going to hand this back to you to continue on with our next speaker.
Awesome. Thank you so much. We will now hear from Dr. Dina Chisholm. Dr. Chisholm is the Nationwide Foundation Endowed Chair in Health Equity Research. She is also the director of the Center for Health Equity and Outcomes Research at the Abigail Wexner Research Institute at Nationwide Children's Hospital and a professor of pediatrics at The Ohio State University.
Thank you for the opportunity to talk with the group this morning. And I was tasked with the unenviable responsibility of reviewing evidence around whole child health and also given 15 minutes to do that. So I had to be a little limited in my scope and really decided to focus a little bit of the energy on how we are promoting whole child health and how we are translating a lot of the really great science that was presented in the sessions this morning. Excuse me. So starting there, I always like to ground my talks in um, kids, in real kids. I think it always helps. We have lots and lots of data, but we want to ground in kids. And so I take an example of an asthma frequent flyer, and I know that's a pejorative term that we really don't want to use, but there are people who sometimes still do. So a youth with asthma who shows up in the emergency department way more often than we would like them to because their disease isn't well managed. And a traditional disease focused approach, the child goes to the emergency department, they get their acute symptoms treated, they get referred to primary care, they get an asthma action plan, they get meds. And from a research and evidence focus, we think a lot about how do lungs work? How does asthma develop as a disease? What are the right ways to test new trials? What are the right interventions to get behavioral change in patients? How do we measure the relative effectiveness of different approaches to disease management? But ultimately, we're focused on the disease. The transition to thinking about focusing on the child is that we don't just wonder why their asthma is getting them to the emergency department uh, often. We have to think about issues of transportation. Can they not get to a doctor's office during the workday because their family only has one car and that car is at work, or the parent is at work and nobody's there to take the child to school? Are there issues with finances? Is the emergency department the only place that they can get care? Are there issues with the environment in which they live? Are they living in homes with bugs and triggers? Are they living in neighborhoods with high street pollution and other things that cause asthma exacerbations? Are they living in houses with smokers and other irritants? Are they unsure about the right thing to do? Do they know what the right thing to do is, but they've gone to healthcare systems and been treated really badly and don't go back unless it's an absolute life or death situation? What are the things that are underlying the health of that child that is not about their asthma, that may be exacerbating their asthma, or their asthma may be the least of their problems? So when we're really talking about a whole child approach, we're really thinking about not just disease and medical research, but we're thinking about understanding how health systems and services work, how schools are part of this, and how environmental health is part of this, and other groups. What are the health-related social needs that are impacting the health, not just of that child, but all the children in that household? What exposures are they facing? What biases are they affected? How do we make patients more empowered to make better decisions about their health and well-being? So when I'm thinking about the well-child approach, I'm really thinking about the child at the center of an ecosystem of needs. And so when we talk about whole child health, and this was already presented, but maybe a couple of you only popped in starting now, so we'll remind you that we're talking about the whole child. We're talking about, yes, managing their health condition, but we're also talking about how they function physically. Can they do the things that they want to do? How they focus emotionally? What's their mental health? What's their ability to engage emotionally? What's their social functioning? Are they able to engage with those around them? And really, are they able to maximize their personal potential in a way that is not degraded by their health or their other social issues? So that's what I want to talk about. And what I'm going to talk about is how a few different models are trying to deliver a whole child perspective on care and on health. And like I said, this is not a extensive or expansive or complete literature review. I will, in the final documents that we send out after the event, put together a pretty nice bibliography. But I had to just pull a few things to give you examples of how all of the underlying science of whole child health can be delivered within health and other social systems that touch children. One of the areas that's most often argued as the way that we're going to create whole child health and whole child well-being is through value-based purchasing and alternative payment models. So how does the way that we pay for healthcare impact our ability to maximize child well-being? Why are we thinking the way we pay for healthcare should be able to impact child well-being and whole child well-being? Part of it is because that's where we spend a lot of our money, and we know we put our money where our intention is. And right now, healthcare is about 18% of GDP. I missed a word there, I deleted it. That 5.8 should have a trillion after it. $5.8 trillion in annual expenses, about $15,000 per person. And that's across age groups. So children are in that mix. So we're spending all that money, but traditionally, a lot of that money has been going to sick care. A lot of that money has been going to treating that emergency department visit, treating that hospitalization, and not to how we maximize the well-being of the child underneath that sickness. So the transition to alternative payment models is starting to allow approaches that incentivize whole person health, allow the system to make money based on people being healthy rather than making money based on people being sick. And Medicare and some adult systems have really started to leverage this as a way to maximize health at a population level. But the transition to child health has lagged because, as a rule, children are usually smaller parts of the financial exposure of healthcare systems and payers, so they don't rise to the top of the priority list sometimes. But we are starting to see changes where we are starting to learn that we can impact child health too. So, what are we learning? I'm going to talk about three value-based purchasing approaches. There's lots of them, but again, I've got a limited amount of time. Thinking about patient-centered medical homes or comprehensive care models. These are models that are generally focused on a single provider who is getting paid largely on a fee-for-service basis, so getting paid for each service they provide. But they also have or receive a fixed amount of money per patient to go above and beyond that basic health care. So that additional funding, generally given on a per member per month basis, can provide for care coordinators. It can provide for referrals to food sources. It can provide for referrals to housing supports. And the goal then is to say we're not just doing primary care and we're not just doing acute care, but we're really addressing the needs of patients at the center of their needs in within the healthcare center system. So we've got some examples here from work done in Indiana and work done in Minnesota, where they've shown that when we make that additional investment as a patient-centered medical home, we are able to give families a more supportive relationship with their clinical provider, so they feel like there's someone there who advocates for them, who develops a shared plan of care that they can take around their other providers and provide more consistency, and provide additional systems of support, and also can actually do a better job of making sure people are getting the preventive services they need, because that is a focus not just of the provider, but also of the care coordinator or the community health worker who may be working with the patient. So patient-centered medical homes generally happen at the provider level. Accountable care organizations are generally groups of providers who come together to create an organization that says, we're going to take accountability for this population of patients. We're going to accept a capitated or a global payment for that. And we're going to use that money in a way that is financially positive, which means we keep kids healthy so that we spend less money, which means we have more retained earnings, and we have a healthier patient population. We can see some models of that have been happening, that have been being tested with good results, but certainly more opportunity for testing in states like Massachusetts Medicaid, where there's a new publication coming out in just a couple of weeks from Pediatrics. This is an earlier publication in JAMA Pediatrics. I know it's coming out because I wrote a commentary on it, talking about how we can do a better job of understanding what specific components of accountable care organizations are likely to generate change. And another model in Ohio, Partners for Kids, which is at the institution that I'm associated with, for clarity, that has been able to show reduced overall costs, reduced growth in costs, and improvement in quality in some but not all measures. So accountable care organizations have the potential and are showing the potential to be a way to deliver care that supports whole child health. And importantly, that is sort of generally at a state level or a regional level. CMS is trying to take this to a national level and trying to create models that are replicable across systems. So the um, Integrated Care for Kids model has been focused on using supports to reduce out-of-home placement in children. And the upcoming Aspire model is going to be designed to reduce risks and improve health in children with medical complexity. So, are payment models the answer to whole child health? No, not by themselves because they're often more disease focused than health focused. They still center healthcare, and we can't center healthcare if we're talking about the whole child. Sometimes kids get lost in the mix because adults are more expensive, and ultimately health systems are balancing competing goals, and sometimes the child health goal falls behind financial sustainability goals. So, what else do we need to add to maximize that success? There are a number of whole child-based, evidence-based interventions that can be implemented within a value-based model or within a community organization or within an individual practice. And we will share a lot of resources around some of these that have shown really good improvement in taking care of specific health conditions and meeting the need of the whole child and the whole family. But we also want to say that it goes beyond those evidence-based interventions because ultimately, most of a child's life is spent in their community. How are we able to leverage communities to get to better outcomes? And so I mentioned a couple of these that many of you may be familiar with. The Moving to Opportunity trial that was funded by HUD that showed that we could impact child health outcomes by providing vouchers that supported moving to lower poverty communities that created improvements in asthma and mental health, lowered overall spending, and also showed some evidence of improvements in college attendance and reduced single parent rates, even though the effects were different by age and gender. So it takes a little bit of digging into the results to know what's going to matter. Similarly, the Harlem Children's Zone and Promise Neighborhoods programs that are working at a community level to create improvements in both health and educational outcomes and juvenile justice outcomes and higher education outcomes. And a specific one that I am familiar with at my institution that's really focused on building neighborhoods and is starting to show some evidence of success. We also have to remember that as we're doing this, there are evidence-based safety net systems that we have to keep in play. SNAP and WIC, early intervention, childcare, these all have to be layered on within the other types of delivery systems because we're already making huge investments as a society in these programs. And even as those fluctuate, they are part of the landscape of maximizing child health. And ultimately, the only way we're going to get child health is with shared accountability. Whole child health is with shared accountability. So we're starting to see models put in place where the incentives don't occur at a specific accountable care organization or a specific provider, but at a whole system level where the whole system is part of making change and the whole system is part of the benefits so that we are maximizing whole child outcomes in a way that leverages everyone bringing their individual skills and talents to the table. There's so much more, and I'm out of time, and I know I'm about to get the hook. I encourage you to look at some interesting publications, the Launching Lifelong book has already been mentioned. Another National Academy publication specifically on value-based health for well-being, another pediatric special issue that looked at how we measure child health at a population level across a bunch of different activities. I encourage you to think really big and read a whole bunch of stuff because there's a lot of evidence that this work can work as long as we build on the work that has been done before. And with that, I will stop.
That was great, Dr. Chisholm. That was so packed with information. We could listen to you all afternoon, and you did have a couple more minutes if there's anything else that you'd like to say.
Oh, I did. I thought I only had to. Oh, I was actually leaving time for questions. No, I think that what we really want to make sure that we're thinking about, and the piece that I didn't put in and I didn't say out loud because
Okay.
you can't always say all the things you want to say out loud, is that whole child health is not whole child health unless we address issues of inequities. And I know that we are in situations where speaking to that directly is not always welcome, is not always rewarded. But the truth is, whole child health has to include whole population health. Whole population health has to include health equity. And all of the models that I talked about have a health equity component that can be built on as we move forward.
Okay, that's great. Wonderful way to end that. Great talk, Dina. Thank you. Thank you so much. I am going to introduce a very key speaker here, Dr. Rohan Hazra. He is the Eunice Kennedy Shriver National Institute of Child Health and Human Development Acting Director. And I know we are all very interested in hearing from him and their portfolio at NICHD. So take it away, Dr. Hazra.
All right. Thank you, Denny. This has really been a great morning. So I am here in my capacity as acting director of NICHD, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, to give you an overview of pediatric research at the NIH. And then I'll spend talk for a few minutes about specifically our portfolio here at NICHD. So I think this is an important slide for people to understand pediatric research at NIH. So while we at the Child Health Institute are the largest supporter of pediatric research at NIH, collectively, all of the other institutes and centers support the vast majority of pediatric research. And I think that's part of the reason why we have several of my colleagues here who are going to be speaking after the lunch break. In total, this is approximately $5 billion a year. And my predecessor, Dr. Diana Bianchi, used to like to say that if this were all in one institute, it would be the third largest institute at NIH. But importantly, it's really spread out across multiple institute centers and NIH offices. Similarly, for training of the pediatric research workforce, while we are the largest supporter of pediatric training and career development, similarly, again, the vast majority is actually supported collectively by our partner institutes. And of course, the research portfolio is very broad, so it's a little hard to represent it in slides. So we actually are using this research topic map to cover about a decade of pediatric research at NIH. And so you can see there down at about 7 o'clock, research on genetics and basic science. Then up, we have immunology and infectious disease. We then have clinical research and a number of clinical networks that do clinical trials in various diseases and conditions affecting children. We have a large behavioral portfolio across NIH, and then that kind of merges in down there at about 5 o'clock with the neuroscience and neuroexposure portfolio. So because of how broad our portfolio is, across just about all of NIH. In 2018, our director at the time, Dr. Francis Collins, with Dr. Bianchi, established the NIH Pediatric Research Consortium. And so this was established in 2018 to increase collaboration and coordination of pediatric research across NIH. And I did note that Dr. Bethel, in fact, one of her slides was calling out NPERC, so we appreciate that call out. This is voluntary but very active participation and engagement from nearly every institute and center and many NIH Office of the Director offices. We at NICHD lead this group, but by no means are we by ourselves. I mean, this is really a tremendous participation across NIH. We meet bi-monthly to discuss NIH-wide initiatives, institute and center research portfolios, and areas of common interest. And importantly, it's through NPERC that when different opportunities arise, we are able to establish subgroups that then go much deeper into particular areas. And currently, for example, we have a subgroup on pediatric pain research that aligns with the HEAL initiative, which is helping to end addiction long term. We have a very exciting pediatric medical devices, PPP is public-private partnership that we co-lead with the Bioengineering Institute. Very important topic across all of pediatrics is transition from pediatric to adult healthcare. Again, as I mentioned before, we have many clinical trial networks across NIH, and so we have a group really trying to better standardize and homogenize how they operate. We have a very active subgroup on pediatric pharmacology, and then again, what's key to research for the next generation is making sure that we have the workforce to be able to do those studies. Next, though. Okay. And so this is, I keep on talking about these NIH-wide initiatives. This is just a sample of some, again, for a short talk, this is really just an overview, but just to give you a sense of what we do. So the blueprint for neuroscience, out of this came the Baby Toolbox, which is an online or iPad-based way to do assessments in infants. We support the Gabriella Miller Kids First Pediatric Research Program. I'm sorry for a few typos there. The All of Us Research Program, which now has enrolled over 2,000 children. There's an NPERC group that helps to advise the pediatric team at All of Us. There's an initiative that we co-lead with the Deafness Institute called TALK, which stands for Tackling Acquisition of Language in Kids. There's the Include project with really quite substantial authorized funding from Congress to look at Down syndrome. We'll probably be hearing about the adolescent brain and cognitive development and the HBCD studies later from our NIDA colleague. There's the ECHO program, which is the Environmental Influences on Child Health Outcomes, which is both a set of observational cohorts as well as a clinical trial program. One of the newer initiatives that we've launched with our colleagues at NIMH is the impact of technology and digital media on children and adolescents. And then I already mentioned the HEAL program on a prior slide. Again, this is just an example of some of the things that we're invested in. I did want to call out a relatively new initiative. This was launched just last year, the Autism Data Science Initiative, with the goal to bring together diverse data resources and community members with lived experience to explore novel contributors and or to characterize the collective contributions of numerous factors to, one, the causation of autism spectrum disorder and their potential role in increasing the prevalence. And so currently we're supporting, again, across NIH, 13 projects that draw on genomic, epigenomic, metabolomic, proteomic, clinical, behavioral, and autism services data. Very important, I think, as we hear from the community about the importance of the autism services. And this program is being administered by this very long name, which I won't say, but we just call it DPCPSI, within the NIH Office of the Director, but again, in partnership with many of institutes and centers. I also want to highlight that we have a very active pediatric research program right here on the NIH campus at the clinical center. So this is just to give you, again, just a sense of that in the last fiscal year, the pediatric use of the NIH Clinical Center, there were over 2,000 unique patients from 14 institutes and centers, and that constitutes about 10% of all patients seen at our NIH Clinical Center. We have both outpatient and inpatient, so you can see that the inpatient volume is quite robust. And we also have a capacity right now for a pediatric ICU care and management within an adult ICU. But one of our director, Dr. Bhattacharya's signature goals is to actually build out separate pediatric intensive care unit capacity at the clinical center itself. So there's a nice photograph here from the sky of our NIH Clinical Center. And what this is going to allow is better safety and continuity of care, avoiding risky transfers when children are critically ill here on a protocol. We won't have to transfer them to a community hospital or a hospital in the community, and it enables us to actually really broaden the kinds of studies that we're going to be able to do at the clinical center. A pediatric intensive care unit will enable first-in-child and higher risk trials, potentially allow us to do rare disease research in ages and in conditions that previously we were not able to. And we really are hoping this will also strengthen national partnerships. I also wanted just to call out how we are coordinating the MAHA, or Make America Healthy Again, implementation strategy and governance at NIH. And so Dr. Rick Wojcik, who is a senior advisor to Dr. Bhattacharya in the director's office, is leading this effort. And what we're now establishing, which I think has a lot to do with whole child health, there's a lot of overlap here, is there'll be a steering committee of senior NIH leaders, and then you can see 3 different integration platforms, including whole person health that Dr. Shurtleff, who you'll hear from later, is one of the co-leads for, and then these 7 scientific or thematic coordination groups. So this effort is just now getting established, and meetings are starting of these various groups. And I think one of the key things here is this is not necessarily to do a whole lot of new research. It's really, I think, better to report out what we already do that is achieving or helping to achieve the MAHA implementation strategy of our department secretary. So that's a little bit about NIH. Now I want to talk about some more about my institute, NICHD. So our mission is to lead research and training to understand human development, improve reproductive health, enhance the lives of children and adolescents, and optimize abilities for all. And our overall budget is about $1.8 billion a year. So sometimes I'll get the question, well, in that prior slide, you showed that your pediatric research support is just under $1 billion. What do you do with all that other money? Well, even though child is in our name, we are also the site for non-oncologic, so non-cancer GYN research, pregnancy research, and reproductive health research in both men and women. We also house the National Center for Medical Rehabilitation research, which not only supports a portfolio on rehabilitation research for both children and actually across the lifespan, but also helps to coordinate rehabilitation research across NIH and with other government agencies. And so basically means about a little more than half of our budget goes towards pediatric research, and then separately the other half goes towards the other topics that I mentioned. We issued a strategic plan under Dr. Bianchi back in 2019, and then 5 years later, we did a refresh. So this refresh of our strategic plan was published in January of 2025, so about a year and a half ago. These were the research themes that stayed constant, and you can see here, of course, a number of them that impact on the topics that we're covering today. Certainly, issues around molecular, cellular, and structural basis of typical development is there. As I'll touch on, there are issues around gynecologic and reproductive health that have antecedents in utero and in childhood. setting the foundation for healthy pregnancies and lifelong wellness. And that's really lifelong wellness for both the mother as well as the child, improving child and adolescent health in the transition to adulthood, and advancing safe and effective therapeutics and devices for our populations of interest, which very much include children. We also have in our strategic plan a set of aspirational goals. And, again, sometimes I find those are the most exciting part of our strategic plan because it's really trying to be very forward thinking. How's the world going to look different, not just in 5 years of the strategic plan, but say in 10 to 20 years. One of the areas that we've specifically have called out in this refresh of the strategic plan is well child care, primary care, and the importance of doing more research on what's optimal pediatric primary care. And so that's one I just wanted to call out there as well. And that's leading to us really thinking about some different types of funding opportunities and different types of partnerships as well. And again, just to tell you just to give you some sense of the breadth of pediatric research at NICHD, of our 11 extramural research branches, 10 of them, along with NCMRR, our Medical Rehabilitation Research Center, address pediatrics. And so you can see from the titles or the names of the branches, really all that we end up doing. There's a large portfolio on congenital anomalies, typical child development and behavior, also atypical development. Again, I keep on stressing antecedents for GYN health and disease in childhood and adolescence, pediatric growth and nutrition, pediatric trauma and critical illness, pediatric infectious disease, pediatric pharmacology, pregnancy and perinatology, and then a population dynamics branch that really looks at population health with really a focus on our populations of interest. So really a very broad portfolio even within NICHD. And I keep on mentioning research networks as well. So this is just some examples because we have more than these that we support that both are generating evidence, but then also generally will have ability to provide data and potentially specimens for ancillary studies as well. So we have the Maternal Fetal Medicine Units Network, our Neonatal Research Network. We do the Pediatric Pharmacology and the Congressionally Authorized Best Pharmaceuticals for Children's Act through our Pediatric Trials Network. We have a Pediatric Critical Care Network. We have a large effort on HIV. We are the fifth largest HIV budget at NIH, and a lot of that support goes towards clinical research infrastructure. So one of them is a domestic adolescent HIV network. We have the Autism Centers of Excellence, which we support along with a number of other institutes, and we have the Intellectual and Developmental Disabilities Research Center. So these are just some examples of our research networks that really serve, I think, not only to generate, as I mentioned, new research evidence, but really can also serve as a resource for the research community. And again, various people have talked, and I think we'll probably hear more about this too, but just how technology and digital media have just transformed childhood, right? And so with NIMH, we have developed a research agenda to help guide work on addressing impacts of technology during development. This was with support of Congress, and we co-led a workshop with NIMH. And then we're able to generate this report that is publicly available. So this really lays out a research agenda for technology and digital media. So it calls for modeling the complex relationships between TDM and development, improving measurement and study design, expanding participation in these studies, and building evidence-based prevention and intervention programs. And I think people will see, right, there's a lot of movement of restrictions and other ways to manage technology and digital media are already being rolled out. But I think there are real opportunities then to be able to look at the pros and cons and the risks and benefits of these various areas. And so really a very important area for us with respect to research in children in 2026. And then, as I mentioned, as part of my NIH part of the talk, we have a very active pediatric research program at the NIH at the clinical center. And then specifically at NICHD, we actually have a slot for the Pediatric Scientist Development Program. So this is a K-12 national pediatric research workforce research training program where there can be a scholar that could actually spend their time here at the clinical center and at the NIH labs. And so we have that partnership. We also have a partnership with Children's National Hospital in DC, and really trying to encourage residents and fellows there to be able to come to NIH for their research training. We have a very active adolescent gynecology program here at the clinical center, which includes a training fellowship as well. And just some examples of research that we support within our intramural program are pediatric skeletal disorders, developing wearable devices to monitor pediatric obstructive sleep apnea. And then we have a large portfolio in metabolic disease from bench to bedside. Includes clinical studies in Niemann-Pick disease type C. And over half of our intramural clinical research and portfolio involves rare disease. Then want to just highlight that there's a major move at NIH to reduce the number of formal funding opportunity announcements that we are supporting. So if you're in the research community, you're probably seeing that what we call NOFOs, or Notice of Funding Opportunities, the number of them have greatly been reduced, and the plan is for that to continue. And I'll touch on in the subsequent slide what we're doing to try to get more information out to the community about our priorities. But right now we have currently at NICHD 4 NOFOs that are published and open. One of them is in novel experiential technologies assisting individual learning. And really the exciting proposal here is to address the impact of AI technologies on developmental outcomes in children diagnosed with or at risk for developing a specific learning disability, impacting reading, writing, and mathematics. So we really, our child development behavior branch has really highlighted how important it will be to have active research looking at how AI is potentially going to transform how children read, write, and learn mathematics. We also have a limited competition, meaning this is currently just open to the current centers for the intellectual and developmental disability research centers. We have an HIV-related opportunity using archive data and specimen collections to advance maternal and pediatric HIV/AIDS research. And then we have an opportunity for utilizing our contract resources for contraceptive and reproductive health. So as I mentioned, because we're reducing the number of NOFOs, what NIH has now done is establish these highlighted topics. So these you can Google NIH highlighted topic, and you'll be able to see what are some areas or specific types of studies or specific topics that NIH is interested in. And so what I've listed here are the ones where NICHD are primary. So we have a highlighted topic on the research on the transition from pediatric to adult healthcare. But again, as I mentioned, that's certainly a priority for across NIH. We have a research on drowning prevention. Again, a very, very important issue, a major cause of morbidity and mortality, especially among 1 to 4-year-olds, and again in adolescents. We have the effects of contraception as treatment for gynecologic disorders. We have enhancing the improved funded maternal health research centers of excellence, advancing prevention and treatment of bacterial sexually transmitted infections in HIV-affected populations, and implementation science to optimize HIV prevention and treatment. So these are the highlighted topics for which we are the primary. I won't go through all of these, but these are ones where we are secondary, many of which may be of interest to the group. And with that, I am happy to take questions. I guess I'm not taking questions now. We'll be taking questions later. I don't know how I'm doing on time though, Denny. If there is time, I'm happy to field a question or two now, if you would like.
Well, let's see if anybody has submitted a question in the Q&A. I've asked people not to submit it to the chat. So if anybody has a question for Dr. Hajra, you can put it in the Q&A right now. Let's see. they might not be able to orchestrate that quickly enough. I'm just looking through
Okay.
the chat. There's so much chatting going on that it's hard to track. But that was really an excellent talk, and we will have more time after the rest of the NIH directors speak, which will happen after lunch for those on the East Coast, breakfast for those on the West Coast. But I just want to say what excellent talk that was. And I think people could really get a sense of the breadth and depth of the research that's being conducted at NICHD. It's really impressive and has grown. You can really sort of see the evolution of it. If you've been associated with NIH, as I have for many, many years, just because I'm old, but knowing how much this portfolio has grown. And I also want to kind of bring out to the audience that research to some, especially in communities, may seem kind of disconnected from their daily lives. How is this important to me? How does this map? And, research doesn't occur in a background, in a vacuum. It responds, and the NIH research responds to prevailing issues, in this case, to children's health issues. And so it responds to that, and it develops portfolios that are designed to address those issues, to prevent, to treat, to help, to manage, to track, right? So that we can have better outcomes for children. And what the research ends up doing is giving us evidence so that we know what's likely to work and what isn't likely to work. And that can help, direct us so that we're not wasting money, right? So at the community, at the local level, the state and the federal level, it can direct our precious dollars towards those practices and interventions and treatments that are most likely to work. And again, in this case, for our children and adolescents. And so I really think that came across in your talk, Dr. Hazra, and I'm just so, so grateful that you were here to present that to us. And we'll look forward to addressing, to you addressing questions a little bit later. So for now, we're just going to break for half an hour. Stretch your legs, whatever you need to do. And I am going to, there was a question that came up, Dr. Hazra, but we will save it. We will save it. So I'm going to share again, and we're going to ask you all another question. Let me get to it. Here we go. And the question for this break: what are you seeing in your community to improve child health and well-being? So we want to know, in your estimation, what's working. And we will break for 30 minutes, and we'll come back at 12:30 Eastern Time, 9:30 Pacific Time. Thank you so much for being here. Appreciate it. In response to the question that we had during this break, we had a lot of excellent inputs. So just to summarize, what folks said about what has been working in their communities is expanded collaboration between government, schools, community volunteers, coalitions, and other programs, such as family resource centers and neighborhood improvement projects in urban and rural areas. Initiation of training and hiring of trained behavioral health professionals and staff within communities and schools for mind and body concerns. Increased state-level funding for reading interventions and nutrition with a community prioritized and nuclear family voiced approach. So I thought those were very excellent responses. Thank you so much for that. Like I said, we will be compiling everything and bringing that back to you in our resources about 2 weeks after this webinar, when we'll have the full recording of the entire day for everyone. So I'm going to hand this back over to Maddie Jupina, our co-moderator, and she's going to get started with our Institute speakers. Thank you, Maddie.
Awesome, thank you. Yeah, we are now going to hear from 4 additional NIH Institute leaders. So first, I'd like to introduce Dr. David Shurtleff, the Director of the National Center for Complementary and Integrative Research.
Well, great. Thank you. My colleague Mark Pitcher will be sharing the slides. So Mark, okay, great. Perfect. Can everybody see the slides?
Yes.
Okay, great. Well, first, I just want to thank you for the opportunity to participate in this webinar on whole child health and well-being. And as many of you may know, over the past several years now, NCCIH has advanced the whole person health research framework that aligns very closely with the goals of whole child health by recognizing the physical, mental, behavioral, social, and environmental factors that interact throughout development. On some of the slides, you'll also notice a QR code that provides additional information about specific studies, NIH initiatives, and research platforms. Together, these efforts support a growing evidence base to help children, families, and communities thrive across the lifespan. So next slide, please, Mark. So as was mentioned previously, excuse me, over the last 2 years, several major reports from the National Academy of Sciences, Engineering, and Medicine, together with priorities advanced by the current administration, have really highlighted the need to focus on whole child health. These recommendations build on earlier NASM reports calling for greater investment in promoting children and adolescent mental, emotional, and behavioral health, and I'll talk more about that later. And the need to emphasize prevention, early intervention, healthy development across the life course. Overall, these reports really underscore the need for a coordinated evidence-based approach to promoting whole child health. Next slide, please. So taken together, these reports reach consistent conclusions and recommendations related to whole child health. They identify major gaps in the evidence supporting whole child and family-centered care, the integration of physical, emotional, behavioral, social services, and our understanding of the early biological, environmental, and relational factors that shape lifelong health. So the reports also highlight the need for stronger life course research, better measures of child health and development, larger, more representative samples and studies, harmonized data, and stronger research infrastructure. The reports really call for a shift toward upstream prevention, health promotion, coordinated research conducted in real world settings where children live, learn, and receive services. And many of these priorities resonate very strongly with NCCIH's mission. Next slide, Mark. Which is really to generate rigorous scientific evidence on the safety, effectiveness, and mechanisms of complementary and integrative health approaches. While our vision is to ensure that this evidence informs healthcare and policy within a whole person health framework. So the priorities identified in these recent reports really do closely align with the NIH vision and reinforce the need for stronger evidence to advance whole child health. Addressing these challenges will require rigorous real-world research across settings where children live, learn, and receive care, which is the type of whole person health research that NCCIH currently supports and is well positioned to move forward in this space as well. And ultimately, our goal is to provide the public, patients, clinicians, community leaders, and policymakers with trustworthy evidence, research-based evidence that can improve health outcomes, enhance quality of life, and support more effective and efficient health interventions. So next slide, please, Mark. So really, Americans are voting with their wallets when it comes to complementary and integrative health approaches. This is a slide data from 2012. And in 2012, several years ago, we realized that this is a little bit outdated, but we imagine that if anything, the amount of money spent on complementary and good approaches increased substantially. In 2012, it was 30 billion out of pocket on these approaches. That's an amount comparable to spending on physician visits, and nearly 2 billion of that spending was spent on complementary and integrative health for children. As we imagine, as this continues to grow, particularly families are seeking other approaches to support children's physical, mental, and emotional well-being. It's really essential that we understand how these approaches work through guided by rigorous scientific evidence. And again, this really underscores NCCIH's mission to determine the safety, effectiveness, and mechanisms of complementary and integrative health approaches and their potential to promote whole child health and lifelong well-being. So next slide. The challenge for us, though, for NCCIH is that complementary and integrative health approaches are inherently complex interventions. They include nutritional, psychological, physical components such as dietary supplements, mind and body practices, manual therapies, and may also involve devices and used alongside conventional medical care. These components can be combined in many ways to influence multiple physiological systems simultaneously. Just as one example, acupuncture has a physical, neurological, and behavioral component. As a result, it's important to study how these single and multi-component interventions engage multiple systems or really the whole person. And again, highlighting the need for this whole person health research framework that we've endorsed over the last several years. So next slide. So really, when we talk about whole person health, we're focusing on the entire individual, not just isolated organs, systems, but recognizing that they're interconnected biological, behavioral, social, and environmental factors that influence both health and disease. And rather than treating diseases one at a time and after they occur, whole person health really emphasizes a proactive, integrated approach that combines molecular, cellular, genetic factors, physiological systems, psychological, nutritional, physical, and self-care strategies, community and environmental factors to promote resilience and health optimization. And really looking at the bottom right to the bottom left of the slide, really moving away from a less healthy state and the focus on just treating disease, but rather moving more towards the left on this slide to establish and maintain a healthy state throughout life. And this framework requires the study of complex multi-component interventions and understanding of how they influence outcomes across multiple biological systems and scales from molecular to cellular, as I mentioned, organ systems, behavior, social and environmental factors. And by integrating data across all these domains, we can really identify pathways through which interventions can improve health, and we can tailor approaches to individual needs. That's critically important for precision medicine. So next slide, please. So to advance whole person health, NCCIH has been actively collaborating across the NIH to build a rigorous research portfolio. And as Dr. Hazra mentioned earlier, we're working closely with the NIH MAHA strategy team to launch a new whole person health approach to chronic disease prevention research that leverages our collective expertise across the NIH, catalyzing transformative discovery science and intervention strategies that promote wellness, resilience, and optimal health, including metabolic health. And again, this is important for across the lifespan, including whole child health. We've developed the Whole Person Health Index in collaboration with CDC to measure whole person health in research and real-world contexts. We are also engaged in cutting-edge whole person artificial intelligence research under the NIH Bridge to AI initiative. Through the NIH Whole Person Physiome, we are working to understand how biological, behavioral, social, and environmental factors interact across organ systems to shape health, providing really a foundation for more personalized and proactive health care. Importantly, these concepts are being useful and used and are being translated into clinical practice. Just one example, I think was a good example, a recently supported study supported through the Veterans Administration in collaboration with NIH and the DoD under our pain management collaboratory. The W-HOPE trial showed improved chronic pain-related functioning more than either cognitive behavioral therapy or usual care. And finally, we're leading the NIH Emotional Wellbeing Research Network to develop and further develop this concept as a key component of whole person health, and we believe a key component of whole child health as well. So next slide, please. So the NCCIH Emotional Wellbeing Research Network is in collaboration with the Eunice Kennedy Shriver National Institute of Child Health and Human Development, the National Institute on Aging, the Office of Behavioral and Social Science Research, and the Office of Disease Prevention. And it's really building the science foundation for understanding emotional well-being across the lifespan. The networks are identifying how mind and body behavioral interventions enhance emotional well-being, resilience, and health. They're looking to develop and harmonize measures, advancing research on family and social relationships as key determinants of child health, and examining the biological, behavioral, and social environmental factors that shape emotional well-being throughout development. And in fact, this Monday, June 29th, at our NCCIH National Advisory Council meeting, we'll be receiving an update from several of the principal investigators involved in this network, and encourage you to turn in through the NIH videocast. Next slide, please. In addition, in 2022, NCCIH issued a request for applications focusing on fostering mental and emotional and behavioral health among children, primarily in this case, focusing on school-based settings. Next slide. This initiative really reflects NCCIH's commitment to promoting mental, emotional, and behavioral health through early intervention. And by focusing on school settings, the program reaches children during critical developmental periods where interventions can have broad population level impact. The goal was not only to promote positive mental health and reduce the risk of future mental and emotional behavior disorders, but also to build a rigorous evidence base for complementary and integrative approaches that can be implemented and scaled in real world settings such as school settings. And ultimately, this research will help establish effective practical strategies to improve child health, resilience, and lifelong well-being. So next slide. So from this RFA, we supported 3 clinical trials. The first by Dr. Ling, which is evaluating a novel food, body, mind intervention for preschool children in Head Start programs that combines mindfulness, healthy eating, movement, and caregiver engagement to improve mental, emotional, and behavioral health along with physical health. So by integrating school and home-based strategies in this diverse low-income urban and rural communities, the study aims to generate scalable evidence for complementary integrative approaches that promote whole child health. The second clinical trial led by Dr. Lowe is evaluating a culturally grounded talking circle intervention to improve the mental, emotional, and behavioral health of Native American youth. Using a community-based participatory approach, the study tests whether the school-based after-school program can reduce stress, depression, substance use, and suicide risk while strengthening resilience and cultural connectedness across rural and urban communities. And finally, a study by Dr. Green is evaluating an innovative school-based program that combines mindfulness, youth leadership, and civic engagement to improve mental and emotional behavioral health among youth. Through partnerships with schools in both Boston and Chicago, the study examines whether empowering youth to address community challenge can strengthen resilience, leadership, well-being, connectedness, and health, while providing an evidence-based model that we hope will have broader implementation moving forward, as true for all 3 of these studies. Next slide, please. And that really is the key. Generating rigorous evidence is only one part of the puzzle, right? To really improve health, and this was brought up by Dr. Fishbein early on, the evidence-based interventions must be tested in real-world settings, ideally in many separate locations and systems, and if affected, certainly be adopted, implemented broadly in many settings across the country. That's really the goal of research, is to be useful and used. And that's why NCCIH invests in pragmatic dissemination and implementation research, as do many of our NIH colleagues, as a matter of fact. So these studies help, these pragmatic studies really help ensure that effective approaches supported by NCCIH and NIH are not only scientifically rigorous, but also practical, scalable, and useful, and adopted broadly into real world settings. So overall, these pragmatic research platforms that we support, and I'll get into one example in the next slide, provide really a national resource that supports large-scale real-world clinical trials, in this case, embedded in healthcare systems, to improve care, delivery, and patient outcomes. So next slide. To give you just one example of pragmatic research, this is research supported under the NIH Pragmatic Trial Collaboratory. And that's really an infrastructure that brings together researchers, clinicians, health systems, federal partners to develop practical methods, tools, and best practices for conducting rigorous pragmatic trials that inform everyday clinical decision-making and practice, using what we describe as a learning healthcare system model. And just one example of how NCCIH supported trial under the NIH Pragmatic Trial Collaboratory can inform clinical practice for whole child health is through the Pragmatic Trial now underway, testing Guiding Good Choices. And Guiding Good Choices is an evidence-based parenting program for early adolescence, now being implemented and tested in routine pediatric primary care in 3 large healthcare systems. And so by embedding a family-centered prevention model into real-world healthcare, the study aims to reduce substance use and other behavioral health risks while generating scalable evidence to improve adolescent mental health and, importantly, well-being. So just again, one clear evidence of how we can really promote whole child health into primary care, for example, at scale. So next slide. So looking ahead, and I don't want to get people's hopes up, this is not by no means, no plans are currently underway at NCCIH or at the NIH, but we have been thinking broadly about whole child health. And could there be opportunities or the possibility of, and again, I say possibility, to establish a whole child pragmatic and implementation science collaboratory. And the idea is that, you know, thinking this through, it could serve as a research infrastructure focus on developing research and implementation strategies on where children live, learn, and thrive. So by harmonizing real world data across schools, healthcare systems, families, social services, community organizations, a collaboratory such as this could really support embedded research, develop common measures, and rigorous evaluation of whole child interventions. Again, you know, we're still in the very early pre-contemplative stage, you might say, from a developmental point of view. But thinking this through, using implementation science and strong stakeholder partnerships, this type of approach could really accelerate the adoption of effective programs into routine practice and improve healthcare at scale. So in closing, next slide, please, Mark. I'd just like to say that promoting whole child health requires us to move beyond just treating disease. We need to be more proactive. We need to understand how health develops, how it's maintained, and can be strengthened throughout childhood. And we all know that health is multidimensional and involves important components of sleep, stress management, behavior, connectedness and relationships, family, infrastructure, schools, and the broader environment. And they all interact over time to really shape lifelong health, which is really the goal that NCCIH is trying to promote, and really now, of course, the NIH as well. So, but you know, timing matters. Developmental stage influences, and we know this, how exposures and interventions affect health. It's important, and that promotion of health is really, and this has came up earlier many times actually, is more than just disease prevention. We need stronger evidence on the protective factors and other influences that help children thrive, and importantly, maintain health, well-being, and you know, really build resilience for lifelong health. And finally, context matters. Children's health is shaped not only in clinics and healthcare systems, but in homes, families, schools, communities, and the environments where they live, learn, and grow. And these are important components to developing interventions and studying and doing research in these important environments. So advancing pediatric whole person health will require coordinated research across biological, behavioral, social, and environmental domains, common measures across development, and real-world evidence generated through partnerships across healthcare systems, education, families, and communities. And you know, this is really the promise of the whole child health framework. It's really an opportunity to transform how we promote lifelong health starting early in life. So thank you for your time, and I'll turn it over to, I think Nora's next.
Thank you, David.
Yeah, thank you, Dr. Shurtleff, for describing the child health research, the child health related research supported by the NCCIH. Now we'll go ahead and hear from Dr. Nora Volko, who is the director of the National Institute on Drug Abuse.
Hello, everyone. Good afternoon. I first want to thank Dr. Fishman for organizing all together in this extremely important topic of whole child health and well-being. I'm going to be showing my slides directly, so let me share. Let me see, where is the share button here? Give me 1 second when I figure this one out. Here it is. And now, there it is. Oh my God. Continue to share. And what I'm going to do actually is basically trying to take from where David just ended on many of the areas that one can already intervene with implementation science and new models that enable the support of children so that their well-being can be actually preserved, to a more basic concept of what is it that we as institutes, and certainly in the National Institute on Drug Abuse, where we're addressing the vulnerability that develops through childhood and adolescence for the use of substances and ultimately addiction, with all of the vast consequences that it has through health and well-being. And we come from the perspective of there's a lot of science that has been going on before that. And we have all come to realize that whether it is a classical substance use disorder or psychiatric illness or medical condition, there are multiple parameters that actually are contributing to different risks. And it's not just related to genetic vulnerability, but important characteristics on the environment in which children grow and develop that determines actually what their health outcomes will be at multiple levels. In an era where we are facing incredible advances in technology development and resources and capacity to actually gather and collect very large databases, and with the development of, again, the impressive models that are coming out of artificial intelligence that help us actually track trajectories and identify risk for individuals. Our position as an institute overall is how do we place the research infrastructure that will allow us to take optimal advantage of these advances in order to be able to optimally influence the outcomes for children, well-being, and health. And so I want to focus specifically on two our main initiatives at the Institute, which actually are directly related to that developmental stages that in fact are initiated during pregnancy. 10 years ago, National Institute on Drug Abuse, in close partnership with the Alcohol Institute, and then subsequently with collaborations with many other institutes, including NIMH and NICCHD and the Children Institute, we launched the ABCD study, the Adolescent Brain Cognitive Development. And the reason why at that point was that we were very aware about how important the stage of development between childhood into adolescence and then transition into adulthood overall is, as it relates certainly for substance use disorder, but also that period of life is extraordinarily consequential in terms of creating the infrastructure and the health of an individual as they develop later on in life, as well as their educational attainments. So we launched the ABCD study in 2016, and with the idea of following close to 12,000 children at that time until they transition into young adulthood, and periodically evaluating them for multiple parameters that cover a wide variety of physiological systems as well as the brain, but also with deep phenotyping for their family characteristics, their social environment, and their behaviors. And this study, from the inception, we wanted to construct it as an open access study such that we could bring that information to any researcher across the United States or other places in the world to inquire it. And so we wanted to democratize science and to provide that knowledge. And that's how it started. And now we are at the 10-year mark. And I'll give you an update on it because it has been extraordinarily successful. And I would say probably is the most successful study that we've ever launched at the ABS, at NIDA, in that it has had an impact way beyond what we would have thought of, but also extremely relevant to the topic of today's seminars, which is whole child health and well-being. It was so successful that in 4 years ago, we launched a study that actually does the same thing as the ABCD, a longitudinal study, except that it's initiated in pregnancy with the idea to be able to cover those first 10 years of life, which are also incredibly consequential in building up the strengths, resilience, and the characteristics of an individual. And again, as for the ABCD, we want this study to be able to provide the data for researchers to inquire it and to build up the models that in the future, through artificial intelligence, will enable us to identify unique characteristics, and that in the future will allow us to do two things. One of them, personalized intervention, but the other one that David was speaking extensively at, start to link the different physiological systems with the brain and with the diseases that when this happen, but also with the environment. And the ABCD study, which actually just illustrates it here, is a 10-year longitudinal study in which every single year the participants have been actually evaluated and screened for multiple measures. The only measure that's not done on a yearly basis, but every 2 years, is their brain imaging battery that's assessed not just brain structure, but also several parameters that relate to brain function to see how the brain is actually being modified during this developmental stage, but also how the environmental conditions that these children lived in influences that brain development, and how then also that is affected by genetics, to create a database that will enable us to do what we all know all along, that there are multiple factors that are shaping the health of an individual, and that these factors start very early on in infancy. This one started at age 9 to 10, but with the HPCD, we're starting, as I say, in pregnancy. So we have done in-depth phenotypic characterization, but we have also linked the data to locators that actually allow us to look at spatial demographic patterns of the neighborhoods that these children live, community health burden, policies related variables, natural spaces, weather and exposure, air pollution, a wide variety of factors that epidemiological studies have actually documented that they were very, very relevant for children's health and well-being. So that's what the ABCD, and it's deposited on a yearly basis, the data for researchers to inquire it. So it has been extraordinarily successful, as I say. As of now, this is for the 9 years, the last 9 years, 95% of the participants have been retained. And the data being open access has resulted in a wide variety of publications, more than 1,800 as of today. This is all data. But most of it, though, interestingly, has been from investigators that have nothing to do with the ABCD. So any one of you that is interested on querying a particular aspect that actually arises from your practice can go back and work with us in case that you need guidance of how to actually start working with this data. Below, you see the diversity of the papers that have come up with the ABCD. Initially, of course, being the National Institute on Drug Abuse and the National Institute on Alcohol Abuse, our main partner, we were interested on seeing what factors relate to substance use and put at risk. But of course, between 9 to 10 to 19 to 20, the rate of substance use is relatively low, but then there are many other parameters that are very consequential. And you can see, for example, that the main series of papers that have been published out of these databases that are generated from the ABCD relate to mental health. and which is not per se surprising. And many of those relate not per se to psychiatric diagnosis, but to characteristics that in the past clinicians have identified as being of greater risk for negative outcomes. So in this prospective domain, for example, we can actually look at whether those early characteristics are indeed associated later on with a diagnosis of diseases or with worse outcomes. Multiple other papers have come out of physical health, and I want to reiterate, yes, David said it's the whole child, yes, and the way that your inflammation system, the way that you actually, your lungs, asthma, all of those are influencing the brain, are influencing behaviors in ways that is not just one disease at a time. They are influencing one another. Multiple papers on cognition. It has given us an incredible insight in the diversity and the importance of friends, family, and community. And you can see it there. And the diversity of the information that we're gathering is increasing. If you were to ask me, since I basically, of course, I've been looking at the ABCD very, very closely, perhaps what is the thing that I find most impressive about the information that we've gotten? And we've got a lot of information. It has changed a lot of the ways that we've done research, including in neuroimaging. But perhaps the most consequential is in being able to illuminate how socioeconomics actually influences the impact of brain development, behavior, and health. And for example, this study, which was the first one to know this, which was published 6 years ago, actually was looking at the effects of lead in the environment in terms of effects on cognition and on brain development of these children. And yes, they found out, as you would expect, that if children living in areas with high lead exposure have lower cognitive performance, and they also have smaller brain volumes and cortical thickness, as to a certain extent you would have predicted. But what was very consequential of this study is that they basically observed that not all of the children were responding the same way, and that a unique factor that determined the extent to which there was an adverse effects of the lead exposure to these children was the socioeconomics of the family that children lived in. The income of that family determined whether you had a negative outcome or not by lead exposure, which you can see in the diagrams where you see in blue, those are children in high income families, whereas in orange, those are children in low income families. And you can see there that it is in those children that the lead exposure is associated with negative outcomes, but not in the other ones who are able to buffer them. So this is an example of a study that has shown how important is the income and the resources that are given to that child in that family to be able to overcome multiple negative consequences that have been associated with socioeconomics, or with actually not per se socioeconomics, but with adverse environmental insults. Similarly, these studies have also shown it's not just your family income. You can come from a high family income, but if the neighborhood in which you actually grow up has very adverse consequences, despite the fact that you have the high income, that can negatively influence your outcome. So they are both important at the level of the family, but also at the level of the neighborhood. And beyond that, the studies are showing us not just, yes, it's negative, there's interaction, but which areas of the brain has more influence, which functional processes are more disrupted by these adverse consequences. And so how is this influencing the world that we're actually trying to all improve in terms of the outcomes for children, their treatment, their prevention, their building of resilience? And there are many ways that you can show the metrics, but I actually want to go beyond scientific papers, which has, as I show, was very successful. But the data that has been gathered from the ABCD and the papers have been used and cited on more than 95 clinical or other guidelines all over the United States, but also all over the world. And so it is an impact that pertains to we gather knowledge, and that knowledge in turn is influencing the interventions that we do and the way that we characterize the outcomes for these children as a function of what is available to them. And in the lower part, you see actually three examples about how powerful this database is. The study was started in 2016. So, of course, you may imagine that the COVID pandemic gave us an opportunity to see how the social stressors influence the development of these children and their health. And again, that one showed that the responses of these children, which were no longer going to school, but actually isolated in their homes, was very much dependent again on the income of the families. And the stress of the parents in particular determined how much those children then went on to report higher psychiatric symptoms of depression and anxiety during the COVID pandemic. These studies have also informed about how actually less sleep than that recommended by the pediatric associations negatively impacts the brain development and how. And it has also another example that where it has provided us a database that is not available in any other way is how the patterns of screen use are influencing the brain of the children, but also their behavior and the risk for anxiety of depression, as has been shown, depending on what type of social media you are using, but also documenting that in some instances, the use of screens can have beneficial effects. Again, explaining that there is not just one path, but there are multiple trajectories, and understanding that diversity in the neurodevelopmental trajectories is crucial in order to be able to go into the personalized intervention. So the ABCD made also very aware of how important it is to actually create that data, that information. So we started 4 years ago, and the study was started enrollment in 2023, though we funded in 2022, the HBCD, which instead of starting at age 9 to 10, it starts in pregnancy. And as of now, the investigators have recruited 5,000 participants have been enrolled. We have actually prioritizing mothers who are taking substances overall. And in terms of how the representative sample, we are finding that approximately 35.6% of women that have been recruited into the study actually have had exposure to a substance use. And even though this is slightly higher, it's not much higher than the general population, which highlights, again, an intervention that we know by itself could have negative consequences to whole child health and well-being. And the data, actually, since it's been going on for 4 years, has already been deposited. We have 2 data released, the largest, actually, brain imaging data sets that have ever been done in infants. And just like the ABCD, this actually, the HBCD will be doing repeated scanning, repeated measurements on the children and the parents. So I'm going to just show you how this information, because I want all of you to be aware of it in order for you to actually take advantage of it, because this is a resource for everyone to use. Because at the end of the day, the extent to which we can apply that knowledge can help us develop better interventions. So this is one of the studies. It's a preprint. It hasn't even been accepted formally for publication, but it is quite intriguing because using the largest database for fMRIs and structural MRIs that exist in the world in 1-month-olds. These investigators compare the development of the brain at 1 month between children whose mother has been exposed to cannabis versus those that did not. And what is really remarkable in looking at the analysis and understanding it in the context of other studies that have been published is that the main finding associated with negative impact in exposure with cannabis is abnormalities in white matter tract. And of course, this is extraordinarily consequential in that the white matter tracks are what enabled us to generate communication with the different areas of the brain, which is one of the key aspects that makes the brain such an extraordinary system. It is one of the most complex networks of networks, and for the brain to function properly and develop, it requires these network connections, and the white matter is one of them. So obviously, this is the beginning. This is 1 month old, the infants. And the question is going to be, as these children grow, how do these early changes in the brain ultimately influence further development? And that information is not just of interest academically, but it's of interest practically, because if we understand it, then we are in a position to guide interventions to actually try to buffer those changes. So we are at the stage with the HBCD that we're covering that first decade, but with the ABCD, we are on the transition into young adulthood. And this is the period where you start to see the emergence of a wide variety of health conditions. And the ABCD, as we think of moving into the next, the 2.0 ABCD, which we call ABCDE, aims to study those next 10 years from 20 to 30, which will allow us to then link these trajectories to ultimately health outcome. And it will allow us also to achieve what I would hope will be the way that we practice medicine, a way of understanding how different organs and systems work with one another. And it's also the period, again, being a psychiatrist and working on in substance use, where you start to see an increase in the diagnosis of serious mental illness. And also you start to see an increase, a very significant increase, not just in the use of substances and drugs, but also in the transition to substance use disorder, again, with all of the negative consequences that that has to other conditions that then go on into chronic conditions overall. So to just end, the ABCD and the HBCD is a main initiative for the Institute that opens up a knowledge towards helping us better craft and understand interactions, and importantly, to delineate paths that can guide precision medicine so that we can provide the optimal interventions as a function of the context of a particular individual. And with that, I want to thank you for my attention. And I think that the next presentation may be given by Andrea, but I am not sure, and I'm going to stop sharing.
Yeah, thank you so much, Dr. Volkow, for presenting the important investments of NIDA to our understanding of the developmental trajectories leading toward or away from substance use. Before I introduce our next speaker, I just want to briefly remind everyone that the full bios for each of our speakers are linked on NPSC's webpage for today's webinar if you want to learn more about them. And I also want to highlight that after we hear from our next two NIH directors, there will be a Q&A session with them. So do stick around for that if you've got questions. And now I'd like to welcome Dr. Andrea Beckel-Michener, the Acting Director of the National Institute of Mental Health Research, who will speak about their research portfolio in the child health space.
Great. Thank you so much, Maddie. And thank you, Dr. Fishbein, for managing my slides with my technical issues this morning. I appreciate that very much. So thank you all for the opportunity to participate on this panel alongside my colleagues and other esteemed presenters. As Maddie said, I'm Andrea Beckel-Michener. I'm the Acting Director of the National Institute of Mental Health and the Deputy Director of what is called the BRAIN Initiative, the NIH BRAIN Initiative. And I'm excited to be here today to highlight some advances and share some opportunities that NIMH is putting forward to support youth mental health in the youth mental health research space. Next slide. So I'm going to tell you a little bit about NIMH, talk about the burden and prevalence of mental illnesses. I know some previous speakers have touched on this, and then share some of these priorities and finish with some specifics around our American Indian, Alaska Native youth mental health research portfolio. Next slide. Okay, first we're going to do NIMH. Sorry, I didn't know that one was in there. Another one. Thanks. Another click. Yeah, great. So NIMH is the lead U.S. government agency for supporting research on mental illnesses. At any given time right now, especially, we have about 3,500 research grants and contracts at universities and other institutions around the country and overseas. And again, we have an intramural research program, which is shown both at the top picture and the bottom picture, where we have clinical science on campus, as well as basic and translational science done by our intramural scientists. That we support about 600 scientists working on the NIH campuses. As Dr. Hajras mentioned earlier, we do have the fourth largest investment overall for all the NIH investments in pediatric research. And we are third in training new researchers. So keeping that pipeline strong is very important to the Institute. Next slide. So I'll give you a little bit of statistics on, thank you, on the burden of mental health disorders. So as we all know, mental disorders are burdensome. About half of American adults have reported a psychiatric diagnosis in their lifetime. Based on data from the Institute for Health Metrics and Evaluation, or IHME, mental health and substance use disorders were the second leading cause of disability in the United States in 2023. Those are our most recent numbers. Just over 15% total, with mental disorders representing 7.3% and substance use disorders representing 7.8%. This figure presents cumulative dailies over, this is US disability adjusted life years over the lifespan. What's particularly concerning is that the burden of mental illness and substance use disorders, represented by the orange line, starts early in life, as Dr. Bokov was just saying. It has been well documented that the most common psychiatric disorders emerge during childhood and adolescence. And because most mental health and substance use disorders tend to be chronic and recurring, this means that many individuals carry this burden throughout much of their lifetime. Additional background, so I guess I'm not going to spend so much time on some of the statistics. We can return to that. So next slide, please. So estimates of the prevalence of mental disorders among adolescents indicates that these disorders are highly prevalent. So this is a figure from Marikangas et al. Found that in the National Comorbidity Survey replication, estimated that, again, lifetime prevalence for any mental disorder among adolescents aged 12 to 17 was about 50%, and 22% of the prevalence of mental health disorders with severe impairment and or distress. More recent data from the National Survey on Drug Abuse and Health found that 15% of adolescents aged 12 to 17 have a major depressive disorder, and 11% had major depressive disorder with severe impairment. Next slide. The CDC WISCAR system has tracked suicide rates across age ranges in the US for many years. From 2001 to 2024, estimated crude suicide rates for youth have increased. As you can see with the blue line in this graph, suicide rates for youth ages 12 to 14 increased from 1.3% to 2.3%. The orange line, suicide rates for youth aged 15 to 19 increased from 7.9% to 9.4%. And in the green line, that represents youth from 20 to 24, age 20 to 24, which increased from 12% to 17%. It's worth noting that suicide rates were higher at recent time points. 2021, this correlates with our COVID pandemic, saw the highest recorded suicide rates for youth ages 20 to 24, as well as higher rates for ages 12 to 14 and 15 to 19. So since then, while suicide rates for these age ranges have generally been dropping since 2021, they remain elevated compared to earlier years. Next slide. This CDC WISCAR's graph data provides estimates of suicide rates by race and ethnicity, which reveals visible differences in the rates. Notably, American Indian Alaska Native youth aged 12 to 24 have distinctly and dramatically higher suicide rates than other races and ethnicities over the past 6 years. I'll return to some of this later in my talk. Next slide. In addition to elevated rates of mental illness and suicide, many youth are also receiving or not receiving mental health care. So the National Survey of Children's Health found that in 2022, nearly 50% of children ages 3 to 17 with a mental or behavioral condition did not receive treatment or counseling, highlighting a substantial treatment gap. We need to combine our current knowledge about effective treatments with emerging health technologies to achieve better outcomes. Next slide. This chart shows how there are differences in the percentages of adolescents across race and ethnicities that receive mental health treatment, again, pointing to significant disparities in service delivery across race and ethnicities. Next slide. We'll talk a little bit about, thank you. NIH's highlighted topics. So because there are a number of researchers on this call, on this meeting, I wanted to talk a little bit about some of our newest ways to ensure that we are getting research opportunities out to the research community. This is quite new. We now have what are called highlighted topics, and there's a central resource, a central list of selected research areas. NIMH is currently participating in many of these highlighted topics, and some of them are relevant to youth mental health, and they include things like school mental health and behavioral health. Again, this point has been made that actually looking at functioning in context and potential delivery of services and treatments in context is extremely important in these real world settings. So we're looking to expand access to evidence-based interventions and services. And schools represent a de facto point of service for health promotion and healthcare in many localities. They will provide a range of health services, or they could provide a range of health services, including mental and behavioral health. So this particular research highlight topic encourages research focused on optimizing and testing school-based mental health and behavioral health interventions and service delivery. Service delivery models includes research-informed approaches that can be rapidly deployed and sustained in school and after-school program settings using available resources and personnel. We also have, as noted in the slide, a highlighted topic on research on chatbots and their usage. Conversational chatbots are increasingly integrated into our daily lives, including use in health information, health-related information seeking, decision support, social interaction, and informal caregiving context. Specifically, there's growing evidence that adolescents are using chatbots with the intent to seek mental health care. These systems are now used by individuals to interpret symptoms, manage chronic conditions, make financial and health decisions, and mitigate social isolation, often without professional oversight. Basically, the technology has gotten ahead of where the science is, where the evidence is. So this topic encourages multidisciplinary research that identifies, measures, and explains the benefits and potential harms associated with chatbot use, both chatbot-based interventions or treatments and routine chatbot use across a variety of populations, use cases, or settings. Of significant interest are studies that move beyond just proof of concept to characterize mechanisms, safety, and impacts on behavior, decision-making, and health outcomes. So both of these examples are highly relevant to not only our portfolio, but hopefully promoting prevention approaches for youth suicide and other mental health conditions. Next slide. So in addition to highlighted topics, the NIH is still promoting specific targeted funding announcements, and these are 3 examples of RFAs and PARs. So those are requests for applications and other funding announcements. The first one is about optimizing behavioral sleep interventions for adolescents and youth adults. This was just recently published this month. So this funding opportunity is seeking applications for pilot research to adapt, optimize, and test behavioral interventions that address common sleep problems in adolescents and young adults at risk for mental health disorders. Those applications are due October 22nd. The next one, PAR 26049, in the middle of the slide, is called Establishing Pediatric CNS Pharmacodynamic Measures as Tools to Enable Psychiatric Indications in Adolescents. Essentially, NIMH, this is what's called a forecasted funding announcement. We intend to publish a funding opportunity that seeks research to determine the best dosing strategies when testing new psychiatric meds in children and adolescents with serious mental illness. This forecasted opportunity really focuses on tools and models that demonstrate how medications affect the brain through functional brain imaging, digital health measures, and/or cognitive assessments. And finally, another forecasted funding announcement at the bottom, advanced laboratories for accelerating the reach and impact of treatments for youth and adolescents and adults, young adults with mental illness. These are what we call our Alacrity research centers. So this has been an ongoing funding announcement, and we're pleased that it looks like it will be reissued. And again, it's to solicit research applications for practice-based research centers to support interdisciplinary teams of mental health researchers. These researchers will engage in high-impact studies to significantly advance clinical practice and transform mental health care for youth and adults in the United States. Next slide. Dr. Volkov actually touched on several of these, but NIMH, just like many of our sister and brother institutes, we do collaborate across the institutes to support wide collaborative initiatives relevant to youth mental health. Luckily, I don't have to go into detail, and a really nice overview of the HBCD and ABCD opportunities. We also involve things with all of us, the ECHO program, and also, as I mentioned earlier, I'm the Deputy Director of the BRAIN Initiative, so I have to plug that a little bit. The BRAIN Initiative is a partnership between federal and non-federal partners, and this is really with a goal to accelerate the development of new innovative technologies for research and clinical use. Next slide. I want to touch on a few of our recent priorities, and some of these again have been mentioned earlier as a high target for research and understanding and building an evidence base. Next slide. First, if we talk about how we understand that adolescence is a period of significant social, behavioral, and physiological and neural development, and adolescents have greater access to spend more time engaging in online social interactions, consuming all kinds of content on social media platforms. However, there's limited knowledge of how these online social and behavior experiences interact with adolescent mental health and the risk for psychopathology. Next slide. Customized, moderated social media platforms can be used effectively to deliver peer support for those at risk with serious mental illness. So NIMH is supporting research to address the issues around social media and digital media use, including research on the connection between social media and mental health, especially among youth. Again, there's a couple of notices of funding opportunity that are noted in this slide. One is about bidirectional influences between adolescent and social media use and mental health. NIMH released funding announcements to encourage applications on this bidirectional relationship, social media use in adolescent mental health, psychiatric symptoms, and the risk or resilience for psychopathology. These announcements aim to address concerns that were just raised in a recent published Surgeon General's advisories on youth mental health and social media and youth mental health. They also aim to address the recommendations of a National Academies of Science report titled Assessment of the Impact on Social Media and Health and Wellbeing in Adolescents and Children. So currently, NIMH is supporting about 25 projects related from these funding announcements, and we hope to encourage more activity in this area. let's go to the next slide because I want to make sure we're having enough time. So great. Yeah, so another focus area with significant activity as well as a high priority for NIMH. We're interested in continuing to fund research related to community-based suicide prevention, acute care, primary care, firearm safety, risk, and protective factors and trajectories, and for preteen suicide. I showed you the numbers earlier and the concerning numbers on youth suicide, especially among certain communities and certain populations. So a few examples of research in this area are noted on the slide. I'll just describe them briefly. In a project led by principal investigator Catherine Pears at Oregon State Social Learning Center, researchers are testing an intervention designed to prevent deficits in children's social emotional skills, as those are known to be transdiagnostic risk factors for many mental health problems and outcomes, including suicide. This intervention is targeted at kindergarten students to provide widely scalable, developmentally tailored, school-based preventative information that will set students on a path toward positive mental health. I gave you those alarming numbers that some of the increases in suicide were happening at very early ages. Another project led by Dr. Nicholas Allen at KSANA Health, researchers aim to improve the Bright Suicide Safety Planning smartphone app for youth at risk for suicide. Researchers are exploring the use of ecological momentary assessment and mobile sensing to automatically push pertinent safety planning information to youth during periods of higher risk. Another project by Dr. Jeff Bridge at Research Institute at Nationwide Children's Hospital, the Center for Acceleration Suicide Prevention in Real-World Settings, will aim to implement effective and scalable evidence-based interventions to reduce youth suicide through the continuum of healthcare settings, including pediatric primary care. Again, many of our studies are targeted to these real-world settings where people will be seeking care and looking for care. I'll mention one more in a project led by Renad Batis at Northwestern University. Researchers aim to implement and analyze outcomes from the addition of a secure firearm storage and safety promotion program to the Adolescent Suicide Prevention in Routine Clinical Encounters trial. So again, we are looking at this from all different angles, and we want to continue to encourage additional research activity in these areas. Next slide. So in addition to these examples of currently supported projects, I just want to highlight a recent publication by Patel et al. That investigated observed suicide mortality in adolescents and young adults after the July 22nd launch of the 988 Suicide and Crisis Lifeline. The 988 Lifeline replaced the 10-digit 1-800 talk number with a 3-digit number and invested more than $1.5 billion to expand crisis center capacity and workforce nationwide. So then when they looked at the subsequent 3 years, contacts in the Lifeline more than doubled, with disproportionately higher use among adolescents and young adults. From July 2022 through December 2024, nationwide observed suicide mortality among individuals aged 15 to 34 was lower than expected based on pre-988 Lifeline trends, as shown in a figure. So this is an example of how we can look at a policy change or an actual real-world change and note the correlation in the drop as we would hope to see. So during this period, 35,000 suicides were observed compared with 39,000, almost 40,000 expected suicides, corresponding to an 11% reduction or around 4,000 fewer suicides in this demographic group. Next slide. I want to talk just a little bit about some of our programs in American Indian and Alaska Native youth. Great, thank you. So suicide prevention is a key concern among tribal leaders.
In 2024, the suicide rate among AIAN adolescents aged 15 to 19 was nearly 2.5 times higher than non-Hispanic white adolescents in the same age group. In 2025, suicide was the second leading cause of death for AIAN individuals between the ages of 10 and 34. NIMH developed the Ask Suicide Screening Questions, the ASQ tool, which is a brief, validated, standardized suicide risk screening tool approved for use of all ages. All patients aged 8 years and older will receive ASQ screening at any visit within an Indian Health Service clinic or department. NIMH partnered with IHS to assist with the implementation of the ASQ tool at IHS clinics and departments, and primarily assisted with a train the trainer events, many events across 10 service areas to train up the service units to use the ASQ tool ahead of the September 2025 start date. The next phase of implementation includes identifying processes for data collection that will support the tracking of screening rates across the enterprise. Quality improvement teams will also initiate a Plan, Do, Study, Act iterative process to develop systems, again, for continuous improvement is what we hope to see with this. Next slide. I'll talk a little bit about PC Cares. This is a project led by Dr. Lisa Wexler at the University of Michigan, promoting community conversations around research to end Native youth suicide in rural Alaska village. Oh gosh, here goes my technical issue again. Can you all hear me? I'm going to assume that you can hear me. Okay, good. Sorry, I keep getting flashes on my screen. Thank you so much for all the emoji confirmation. In this project, let's see, where am I? Facilitators in Alaska are aimed to teach service providers, family and friends what works from prevention science, host discussions to adapt this information to the Alaska Native community in cultural contexts, and assist stakeholders in completing culturally relevant suicide prevention and health promotion. The goal of this intervention is to enhance knowledge, skills, and attitudes among service providers, family members, and tribal residents so that they promote well-being, recognize risk, support vulnerable youth, and work with others in their community to take supportive and safety actions when they notice signs of vulnerability. I can never pronounce this, but so I'm not even going to try, but the translation into English is Little Holy One. So in this study, Dr. Teresa Brockie at Johns Hopkins and researchers are developing, adapting, and evaluating an intergenerational prevention intervention, again, translated Little Holy One, with Fort Peck, Assiniboine, and Sioux caregivers and their 3 to 5-year-old children. It takes place in Head Start, and it will be implemented by Indigenous community health workers. Through this study, researchers and research partners aim to reduce symptoms of trauma and everyday stress among parents and caregivers to improve their children's emotional and behavioral and developmental outcomes to hopefully further reduce future risk for suicide and substance use. The intervention will consist of 12 weekly individual lessons taught to parents and children by Indigenous community health workers, a delivery strategy selected to enhance participation, engagement, local acceptability, and sustainability. I think that does it. So next slide. Yep, this concludes my prepared remarks. I will have to leave the panel, unfortunately, before the Q&A session, but I'm hoping my NIH colleagues can cover many of the questions, and I'll be more than happy to address any questions that come in after the fact, and Dr. Fishbein can send those to me directly. Thank you so much.
Thank you. That was great. Thank you.
Thank you so much, Dr. Beckel-Michener. We will now hear from Dr. Brigitte Weideman, who is the Chief of the Pediatric Oncology Branch of the National Cancer Institute.
Hello, everybody. I hope you see my screen correctly. Otherwise, I can flip. Let me know.
You need to flip.
Okay, thank you.
Yes.
Awesome. Yeah, thank you so much for allowing the NCI to present on pediatric research across the NCI as part of this symposium today. I show you an overview that everyone knows, but I still thought I would highlight unique aspects. Most of the NCI funding goes to extramural, but a substantial portion is with the intramural program, where we have the Center for Cancer Research and the Division of Cancer Epidemiology and Genetics. And both of these divisions utilize heavily the NIH Clinical Center. And in broad strokes, I think the intramural program really tries to do things that would be difficult to do extramurally, and that makes best use of the unique resources that we have in the intramural program. To just give a bit of an overview, pediatric cancers, all pediatric cancers are rare, with less than 20,000 new diagnoses per year. This is about 1% or less than 1% of the adult cancers. And with us, there's limited economic incentives for private sector development. Therefore, pediatric oncologists for many years have collaborated both intramurally and extramurally to most rapidly translate basic and clinical findings into effective trials that hopefully are also more effective and less toxic. Mitigating the effects of therapy is really a very important aspect to us, because the treatments that we have to date leave many patients with lifelong disabilities. Very importantly also, and we heard this today, is the importance of psychosocial and behavioral care and research for the pediatric, but also for the adolescent and young adults that we see, and to assessing the impact on normal development. And then with novel advances in early diagnosis and identifying genetic predisposition for cancers, we're working hard to hopefully push the envelope to earlier diagnosis, interception, and potentially prevention of cancers in children. This is a complicated graph, but it gives an overview of research across the NCI. On the left, you see the different divisions, and on the right, extramural divisions, and on the right, you see the intramural divisions. We collaborate across the board, but I did want to highlight in particular the Division of Cancer Treatment and Diagnosis, which houses the most important clinical networks, including the Children's Oncology Group. There's a STAR Act biobanking effort, the Pediatric Early Phase Clinical Trials Network, and the Childhood Cancer Survivor Study. These are all supported by the NCI and collaborate intramurally, extramurally. I also want to highlight the Division of Cancer Biology that conducts and supports a lot of more the basic research that we hope to translate into the clinic. And then I will talk a bit more today, being myself from the Center for Cancer Research, about our intramural divisions. Shown here, again, NCI Childhood Cancer Networks and Programs. I will provide some update on you on a very exciting effort called the Childhood Cancer Data Initiative, and will also highlight several clinical trials efforts, both from the Children's Oncology Group, but also from the NCI intramural program. And this is for pediatric patients, but also for adolescents and young adults, with the NCI definition of AYA being up to 39 years of age. First, I wanted to focus on the NCI-supported Children's Oncology Group, the largest cooperative group in the world, focusing on pediatric cancer. This is actually an international group. Australia, Canada, and some other international sites are members. The COG has more than 200 institutions, has currently 50 or more NCI-supported clinical trials open, and more than 12,000 experts. Clinical trials conducted by the Children's Oncology Group really define the standard of care and have very much contributed to the overall success story that we see in pediatric cancers. I'm showing you one example here of a phase 3 trial that was conducted in newly diagnosed children with acute lymphoblastic leukemia, where to the typical standard treatment of a chemotherapy only, blinatumomab, an immunotherapy drug, we call it a bispecific T-cell engager that simultaneously binds on CD19 and CD3, was given in the upfront setting to newly diagnosed patients. And you see the dramatic difference in the rate of relapse. So blinatumomab plus chemotherapy has now become the standard of care in children with standard risk BALL. These studies require a large cooperative group, and I think this is a great example why we have made progress. I would like to now move on to the NCI Childhood Cancer Data Initiative, which was started in 2019 and announced during the State of the Union, and provides 50 million of funding per year for 10 years with the goal to develop a data ecosystem that allows us to learn and really ultimately benefit every patient with cancer. The data that are collected are broad-ranging from clinical, molecular, outcome, biospecimens, and a very important aspect of the CCDI is that data get deposited near real time in a data ecosystem. One important mandate for the CCDI was to develop a national strategy for clinical and molecular characterization of patients with cancers. And so, in collaboration with the Children's Oncology Group, a protocol was developed where newly diagnosed patients with the tumors that you see here in the right panel, CNS, soft tissue sarcoma, rare tumors, neuroblastoma, or Ewing sarcoma, have the opportunity to get state-of-the-art molecular profiling. At the time of diagnosis, results are returned within 2 to 3 weeks. And this has allowed enrolling a very substantial number of patients and provided molecular but also clinical information that was simply not available previously. It has also helped patients that are not at an institution like St. Jude or Children's Hospital of Philadelphia to get the clinical sequencing that we think children with newly diagnosed cancers should have. We have more than 9,500 participants, and these findings have resulted in a refined diagnosis, in targeted therapies, and in clinical trial participation. So this has been, I think, a wonderful effort with this data being available to researchers across the world. In addition, I wanted to mention a very exciting study on very rare pediatric solid tumors. And by that, we mean less than 2 cases per million per year. So we may in the US have only 50 cases or even less. This is a longitudinal observational study for children and adolescents and young adults, a registry that we hope will help include real-world data sets and hopefully inform trial design and potentially the development of external controls for interventional trials. Last fall, the president signed the executive order directing HHS to use artificial intelligence to improve research and treatments for childhood cancer. The order included a directive to NCI to increase funding for CCDI by 50 million, bringing the total investment to 100 million per year. So over the past years, as I already alluded to, the CCDI and the Molecular Characterization Initiative have really evolved into powerful platforms for applying new AI tools. And I give some examples here that we could look at. As one example, we have thousands of H&E tumor images. We have imaging data on patients that would hopefully allow us to develop new modalities, how we can analyze childhood cancers and potentially direct better therapies. So this is a very important aspect that we're very excited for, and we are very much hoping to get grant applications that will focus on pediatric AI applications. I'm now switching to the intramural program and to clinical trials that we conduct here, where we believe we can complement the efforts that are going on by the Children's Oncology Group and other external groups. One highlight I would like to give is for the NIH Rare Tumor Clinics. The first Rare Tumor Clinic was initiated in 2008 by Dr. Lee Hellman, and this is conducted now by Dr. John Glott. It started with a rare sarcoma called gastrointestinal stromal tumors. And these were patients that lack KIT or PDGFRA mutations. Clinically, we saw that these patients don't respond to the standard treatment of imatinib, which blocks KIT and PDGFRA. These were younger patients, typically women. And then through the clinics, the concept is that we bring patients, advocates, clinicians, and researchers from across the country with expertise and interest in a specific tumor on the same day. Patients undergo detailed clinical evaluations, tumors are evaluated. The patients get to meet with the experts, includes genetic counseling, psychosocial efforts, and these clinics have really dramatically increased the learning. In the case of wild-type GIST, we identified that succinate dehydrogenase mutations are the underlying molecular cause for these tumors. We have refined clinical strategies for the best management of these patients, and specific clinical trials are ongoing. This has been expanded to a number of other rare tumors, and I feel is really a highlight of what we can do at the NIH Clinical Center. The other example I would like to bring is for drug approvals for very rare pediatric and or adult cancers. And this is another collaborative effort of the pediatric oncology branch with Dr. Alice Shen from the Division of Cancer Treatment and Diagnosis. She had developed a multi-site clinical trial of an immune checkpoint inhibitor for a very rare cancer called alveolar soft part sarcoma. Alveolar soft part sarcoma had no standard treatment options, and frequently patients present with metastatic disease, as you can see here on the chest CT of a 12-year-old female. This trial was open at multiple sites, but the only site that was open to children less than 12 years old was the pediatric oncology branch. The trial enrolled 47 patients. 3 of them were pediatric patients. The waterfall plot here on the right-hand side shows you the responses that were achieved, which were remarkable in that it was a 42% partial response rate, but very importantly, the responses were prolonged and lasted for longer than a year. Based on this relatively small study that was not randomized, the FDA approved atezolizumab for children and adults, highlighting how important it is to get pediatric patients where the biology is similar to an adult cancer into clinical trials that are typically currently designed for adult patients. The next example I wanted to bring from the intramural program was the development of effective therapies for neurofibromatosis type 1 related plexiform neurofibromas. There was no effective treatment for these histologically benign peripheral nerve sheath tumors. However, these can cause substantial clinical problems and transform to malignancy. This was an NCI Pediatric Oncology Branch coordinated but NCI CTEP, Cancer Therapy Evaluation Program, sponsored trial. We enrolled only 50 patients and were able to observe partial responses, tumor shrinkage in 68% of the patients. Very importantly, given that this is not a cancer, we had incorporated functional and patient-reported outcomes and could show an improvement in pain and in function in the patients. This compared with demonstrating that compared to a historical control group that had not received the MEK inhibitor, the progression-free survival substantially improved, resulted in FDA approval. Our natural history study contributed to this approval, and I do think we could only have done this at the NIH Clinical Center as an example of a rare population that would potentially otherwise not have an approved drug. And then the last example that I would like to give for intramural work collaborative with the extramural site is CAR T-cell therapy for acute lymphoblastic leukemia. Most of you will know that CD19 targeted CAR T-cell therapy was approved by the FDA for children that have ALL that expresses CD19 because there were dramatic response rates in these patients. However, subsequently, it was learned that about 30 to 50% of the patients treated will develop relapse. Work that was started intramurally by Dr. Crystal Makel and Dr. Terry Fry, who now collaborate with us out of Colorado and Stanford in California, led to the development of another CAR T-cell approach targeting CD22. This resulted in the development of an NCI trial where patients with refractory, relapsed CD19 negative leukemia after receiving CD19 CAR T-cell therapy enrolled. This resulted in a very high complete response rate, FDA breakthrough designation, and an adult registration trial is currently ongoing. We obviously, as pediatric oncologists, hope very much that this will also result in a pediatric trial. I think this shows nicely the interplay between intramural and extramural collaborations. During today's talks, the importance of behavioral health was mentioned, and I couldn't agree more. We do have in the intramural program the behavioral health core that supports the mission of the Center for Cancer Research by providing specialized neurobehavioral and psychosocial research and clinical care. So for all of our patients, they are supported by this team. We assess patient-reported outcomes, cognitive functioning, and characterize the effect of diseases, especially of rare diseases, over time. We conduct these evaluations on observational natural history studies, but also on treatment studies, for example, where we assess the effects of CAR T-cell on neurotoxicity. And we provide clinical care not only to the patient, but to the families, and we train the next generation of behavioral health professionals. Other things that the behavioral health core does is develop new patient-reported outcomes. For example, assessing tumor-related pain in neurofibromatosis type 1. Develop behavioral health interventions, such as acceptance and commitment therapy for chronic pain, parent stress, and physical activity for cognition. In addition, there's an effort on helping transition of pediatric to AYA and adult care. And we develop and disseminate new resources globally to improve the psychosocial care and quality of life of children and their families. Dr. Lori Wiener, who is the co-director, co-developed the first standards of psychosocial care for pediatric cancer patients. So we're very grateful for this resource that helps us treat not only the cancer, but help the patient as a whole. I would like to spend a few moments on the Division of Cancer Epidemiology and Genetics. They focus on descriptive epidemiology, environmental exposures, survivorship research, and conduct family and natural history studies where there is a genetic predisposition for cancer, but also are in the process of developing interventional clinical trials. For example, a trial of metformin for patients that have Di-Fraumeni syndrome. We are very collaborative between the Center for Cancer Research and the Division of Cancer Epidemiology and Genetics. Their expertise and our expertise combined has resulted in an effort called Advancing RASopathy Therapies, where we are studying the natural history of children and adults with RASopathies caused by germline mutations in the RAS pathway, but also for patients that have somatic RAS-driven cancers. And this has resulted in a very active clinic and is resulting in the first interventional clinical trials. Well, this has been a really short snapshot of efforts that are ongoing. I do think there are opportunities for expansion of pediatric research. I already alluded to the need for inclusion of children in all biologically and clinically relevant studies. Very much to need to incorporate adolescents and young adult patients more broadly, intramurally and extramurally in clinical trials. And I think there's the opportunity to expand critical care and pediatric care capabilities at the NIH Clinical Center to allow for more first-in-human studies and potentially life-saving trials for younger and more medically complicated patients. Thank you so much, and I'll be happy to take questions.
Thank you all so much. This was great. What a tremendous session. We're so grateful to all of you for being here and talking about your investments in children's health, pediatric research that leads to effective interventions and all the innovations that have been so important in the field. So we are going to, let's see if I can, would you be able to take your slides down,
Yes.
Dr. Weidman? Oh, perfect. Okay, so if all the NIHers could come on board. I know Dr. Beckel-Mishner will not be able to join us, but we do have some questions for the rest of you. I'm going to start with some of those from the audience, although I have a few myself to ask. A number of people have actually asked about parenting interventions in education because we know how important parenting and caregiving is to whole child health. And so we're wondering if any of the institutes have been specifically investing in the role of parenting in prevention, but also in managing progression of disease and disorder. And as part of a treatment regimen, we know that whole family approaches are very important for children's health, even if we're not able to prevent something from happening, but to help them manage and to stall the progression of disease. And so is anybody, any of the institutes really looking carefully at parenting interventions or education? Dr.
Yes,
Volkow.
yeah, no, indeed. And actually, it has been one of the areas that has been independently replicated that in terms of what are the prevention interventions for substance use disorder, the most effective intervention is parenting and the family. The parents are the strongest as a, I mean, is that stronger entry into providing protection for children not to be actually going to experimenting with drugs and then substance use disorder. So again, that is the most consequential. Within this context, though, what is very, very intriguing is, and bringing it back to the ABCD, researchers have taken advantage of the really great in-depth phenotypic characterization that includes the family characteristics and the social relationships between the parents themselves within the family and outside. And they've used all of this data, not with any preconceived ideas, to try to determine, including in this one, what are the factors that increase your risk for mental illness or substance or behavioral disorders. And it includes genetics, it includes brain images, it includes a wide variety of parameters. And you can see that the most consequential variables relate against through the family dynamics. And it is not for a specific substance use or mental health condition. Overall, the family structure, all of the measures that pertain to how the family functions, the level of conflict, the level of doing activities together, their involvement in education, in the homework, in providing alternatives for these children to actually have time where they can do physical activity or read. That is the most consequential. So uh, as a result, and again, this is a study that comes out and includes all of the variables together, and it's still the most important one. So highlighting the importance of prioritizing interventions, prevention interventions that target families
Mhm.
And one of the things that's also intriguing, if you want to take it one step further, is that one of the factors that helps families be able to function better is also the level of income. So in families that come from very low incomes, that those interactions are strained by the level of stressors and the multiplicity of responsibilities that they have. So again, here researchers have also shown that providing support to those families, whether it is in the funds of funding or whether it is in the funds of providing them with the help to do certain activities so that they can parent better. That's what overall the research has shown.
Yeah, I think for NCCH, I give one example of the Guiding Good Choices. That's a parenting intervention that we're trying to bring to pediatric primary care. So front and center there is the family competency training, parents, and caregiving. We also, I mentioned the emotional well-being network that involves family as a core component of how we improve and support emotional well-being among children and adolescents, and what that family dynamic and how important that is to promoting health. I think the overall goal of what we're trying to do at NCCH, and I think across the NIH, is, promote resilience, emotional well-being that will be protective factors for disease and disorders like substance abuse, mental health conditions broadly. And so we are very interested in continuing to promote this area of family-based interventions, but in the context of realizing again that it's multi-component. It's not just the family, which is critical, but there's the community, the school, and other environmental factors that also play a role. But again, family and parenting is clearly an important aspect of improving emotional well-being, whole child health, and certainly an area that NCCIH is supporting.
Yes, the whole concept of whole child health is to look at the entire ecosystem in which children live. And so the parenting is critical, as are quite a number of other factors. So it's very interesting. Thank you both. Dr. Hazra, anything on your end?
Yeah, mainly just to say, certainly for us at NICHD, family processing and function is very important, both for typical and atypical development. So, we have a number of research projects there. And then just, David mentioned it, but, the emotional well-being, I think the center that we take the lead on is actually the Family Well-Being Research Network in that emotional well-being network.
Wonderful. Wonderful. Excellent.
Absolutely, yeah.
Thank you. And Dr. Weidman, does NCI, consider the family unit as part of the treatment plan?
Absolutely. And, we're very lucky that intramurally we have the Children's Inn. Children's Inn has a huge focus on family and is expanding this effort. I think it's really the parents, but also the siblings. We have studied the effect of, cancer on the parents and the tremendous burden that this brings, but also coping strategies. But then we do have an effort on the siblings as well. Dr. Wiener hosts an annual siblings day where siblings actually can come and are the star of that day. It's an incredibly important aspect that we do incorporate. Absolutely.
Excellent. Thank you. Anastasia, hello. Hi, how are you? I know her. I would be interested, this is what she has asked. I would be interested to see data from any of the studies mentioned by the presenters related to tracking changes in microbiome composition across time and variables. If none are looking at this, can it be added? David, I believe NCCIH has interest in this.
Oh,
I was on
definitely.
council, let's
Yeah,
recall
you were on
that.
council, I mean, we have a
Yeah.
strong, again, it gets to this multi-organ interaction. I mean, when you think about just a general comment about gut-brain axis, for example, and the role the gut plays in probably many mental health conditions. We have an active microbiome research program. We are actively looking at the microbiome and how it promotes health, resilience. We can certainly provide studies that are currently underway that have been funded through NCCIH. As you may recall, this was a large common fund activity for many years. So we have a very fundamental understanding of the role of the microbiome. I think it's critically important as you talk about, the interconnection of nutrition and health, and certainly the microbiome is critically dependent on what we eat. And with the change in diet, ultra processed foods, we know the diversity of the microbiome is decreased. How that affects health, resilience, well-being, maybe predisposition to disease is critical. We're actively involved in research in that area, and happy to share more information specifically about projects that are underway, if that's helpful.
Yes.
And I was just going to say, we did not collect data on the microbiome for the ABCD, and the intent is, of course, it's very much dependent on the level of resources that we have, but it is our intent on the 2.0 ABCD to actually collect data on microbiome, and hopefully we can, if we get the resources, also add it into the HPCD, because we agree, and certainly in the whole field of brain diseases, the importance of the inflammation trigger and modulated through the microbiome is recognized.
Yeah.
So yes, it's an important area of research. I wish I could have said we had the resources to include it through the ABCD because we would have data. We don't.
Okay, great, thanks. There's so many questions and so little time. Good. I'm trying to prioritize, but they all look so good. So let me ask this one. With the data ecosystem that each of the panelists have laid out, how accessible are those databases for not just national organizations, but for institutions, policymakers, states, counties, and communities? Sort of a broad question for anybody who wants to jump into that.
Well, the ABCD certainly was predicated on the open access, and the same thing with the HBCD, and it's not just limited to the United States. And this open access has been one of the factors that has led to the greatest impact, because you can, as more people inquire into it, they come up at questions that no one else would have thought. But because the data unfortunately has been misused, and actually that has led, and is not per se with the ABCD, but in general on the databases. So now there is a much stringent oversight on access to these databases. But if you follow the training and all of the requirements, many of these data repositories are there for whoever is coming at them from an academic center or a policy organization. And in fact, researchers from policy have taken advantage of the ABCD. So that's the intent, but we also have to be mindful of the potential of misuse of data, the concern about security issues, and confidentiality.
Yes, absolutely. Yes.
Yeah,
And
I'll
no,
just
go
add
ahead, please.
quickly that, NIH for now the last several years has really amped up data management and sharing policy that requires extramural researchers to maximize the sharing of scientific data that's generated. So I think this is really the opportunity to open up these wealth of information broadly to the research community, public at large, but again, emphasizing the need for security measures, confidentiality, and other things that are critically important. But again, it's really the intent. This is taxpayer dollars. The information we collect, support through NIH needs to be widely shared and used. So we do everything we can to make sure that that actually happens.
Yeah. Yeah, excellent. And this it speaks also to our Decade of the Child initiative, where we're really looking at the translational potential of the research that, what are the programs of research that are being incentivized at NIH that lead, they're more applied, that are more pragmatic, like many of you touched on, that can lead, can facilitate that translational pipeline to get that information to communities who stand to benefit from that information, as well as to policymakers who can look at ways of scaling and sustaining that information in order to benefit communities, families, and in turn their children. And so what kinds of translational efforts are going on? Maybe Dr. Hazra, you could speak to that as the pediatric person.
Well, I think one of the efforts, to build upon what David mentioned is I also think, and a big focus of our current director, Dr. Bhattacharya, is actually to try to bring these databases together, right? And have them be federated, but really to be able to link and be able to utilize both research data databases, administrative databases to really get a full phenotypic picture of research participants. But again, as Dr. Volkow said, right, there's the whole issue around privacy, confidentiality, security that we also have to be very mindful of. I think in a small way, the Autism Data Science Initiative that I mentioned is actually trying to build that. I think there was a real push there for again trying to bring databases, both research and administrative and clinical, together to be able to answer questions and generate results.
Yeah, very good. Okay.
I can maybe just quickly add for the Childhood Cancer Data Initiative, they have been able to get data from St. Jude Cloud, others all merged and have a central hub that can access both the Childhood Cancer Data Initiative data, but also data from other places and institutions at the same time. So it's very much an effort ongoing.
Yeah, very good. I would have wanted to ask Dr. Beckel-Michner about whether there's a program of research. Maybe you all know if there's a program of research focusing on the mental health impacts of exposure to extreme heat in children as a timely topic given the temperatures of 107 in Europe right now. Not to mention what's happening here in North Carolina is extremely hot. But do you know if there are any programs of
Yeah.
research on that?
Yeah, Denny, so there's an NIH-wide effort on health and extreme weather. It's led by the NIEHS, the National Institute of Environmental Health Sciences.
Oh,
But
excellent.
many institutes, I know NCCIH, I know Dr. Hazard's been in meetings. I believe NIDA is involved, but many institutes, and we do take the perspective from the institute to help support the health and extreme weather. So we're interested in resilience and models around complementary approaches for example, managing trauma resulting from disaster, or how environmental exposures can be mitigated through complementary approaches. So each institute feeds into and supports the HEW, the Health and Extreme Weather Program, and there are many opportunities for funding through that initiative.
And I'll just add, I think one of the co-leads is the Fogarty International Center. So again, taking a global perspective on this and not, right. And again, I think that's a great example of what we can learn about health and extreme weather globally can certainly inform what we then do here in the United States, right? Because the heat is heat.
Yeah, absolutely. Well, we are out of time, but this has just been tremendous. Thank you all for staying on to answer some of our questions. Like I said, there's so many more, but maybe we can have some discussion offline and we can get that to the audience. So thank you again for your time. I know how precious it is, and I hope you all take care and stay cool. To everybody else in the audience, we are going to take a 7 to 8 minute break and then come right back to you. We have a number of other speakers this afternoon. We're going to talk about the future for whole child health research. We're going to talk about identifying policy and economic levers to sustain impactful change. I'm going to talk about policy as intervention and why that is so important. And so please stay with us. We will be right back. Thank you. Oh, and I have another question for you.
Welcome back from the break, everyone. Now, as we shift our focus toward the future of whole child health research, we'll first hear from Dr. Ronald Prinz. Dr. Prinz is a Carolina Distinguished Professor and co-director of the Research Center for Child Wellbeing at the University of South Carolina. He's also a member of the Decade of the Child Committee.
Thank you, Maddie. Welcome to everybody, and thanks for staying through into the afternoon. Let me start out with this statement. If every child in our nation came down with a preventable physical illness, we wouldn't treat them one by one in emergency rooms. We would change our public health infrastructure. Yet when it comes to the mental health, behavioral, and developmental well-being of our children, we often wait for families to fracture before offering support. Child well-being cannot just be a slogan like Decade of the Child, which is terrific. It must be the moment we treat parenting support and other actions, but parenting support not as a luxury for the few, but as a universal public necessity for all. So all parents and other family providers face challenges in parenting. That's sort of a given, and all the NIH speakers today all said that parents and families are critical to anything having to do with children in their portfolios. I should also mention, though, thanks to NIH and other federal agencies, that there's an impressive collection of evidence for parenting support interventions over 40 to 50 years that is quite demonstrative of the efficacy of many parenting support interventions. However, much of the focus of that work and of the application has been on individual families and less on whole of population implementation. If we wish to make a grand shift from individual crisis to broad prevention, we need a true public health approach requiring an infrastructure that protects entire communities before treatment or crisis intervention is needed. So the status quo, what I'm describing, which is what we're all used to seeing, takes a somewhat reactive orientation with respect to parenting and family support. So certainly Child Protective Services actions, we're quite familiar with that. Mental health treatment, school referrals, legal action, these are all sources of reactive programming. And we're not saying get rid of those. However, that should not be our main way in which we have societal impact. We need to shift to a population-based preventive approach to parenting support that certainly would preserve those actions, but put them in perspective. We need to adopt a destigmatized approach, making parenting support widely accessible, anticipating family needs, and as an important bonus, promote a positive contagion effect across families, which you don't necessarily get from the more individualized approach. So in terms of what I mean by an evidence-based parenting support approach, let me explain. It's not a single program or approach, but there are shared characteristics across a number of programs and strategies. All are seeking to foster healthy parent-child relationships. The emphasis is on practical parenting practices, not abstractions, that parents can make their own, leaving substantial room for parent, family, and group variations and preferences. This is not about dictating to parents, this is the way they should raise their children. No, it's facilitating healthy relationships in the context of the many things parents can do. These evidence-based support programming options do not rely on dogma or preaching. The dogma and preaching really do not have a role. And evidence-based, of course, to this audience and to others, means demonstrated benefits via scientific testing, not simply take it on faith that if somebody comes up with an idea, well, it's that it's going to help. It actually could do harm or make no difference. So if you're going to go to a population approach, you need a flexible framework, but one that doesn't deliver high intensity programming to all families. First of all, you run out of resources very quickly. And secondly, it's not efficient and not effective when you're talking about the whole of population. In fact, this as this pyramid depicts, you need to use different intensity levels with different segments of the population. The most common should be with the bulk of families, universal level, which covers most of the community and relies heavily, for example, on digital and mass communication strategies and very light touch programming, so that many parents can access information and mild sources of support. If they need more, then some families and some parents can benefit from a moderate level, which again, a lower proportion of the population would actually need or desire. And that's when parents can seek out when they need a little bit more than a very light touch, but we would still want to rely on efficient delivery methods. Tier 3, intensive, which is what many of us have been trained over the decades to think of as what parenting and family intervention is supposed to look like. We should hold for a relatively small portion of the overall population. It's not a good use of resources to give people way more than they need when lots of parents can suffice with just a small amount of programming or support. Now, in terms of opportunity points for parenting support, we're all familiar with the different stages of development, from prenatal preparation for parenthood, newborn and early infancy, the toddler years, approaching school entry, all during school, education, during educational development, approaching puberty, teen years. These are the classic time periods when parenting support strategies can be crafted to fit the developmental needs of parents working with those age children. Some parents have children in multiple ages at the same time. And there's some cross-pollination of concepts, but it needs to be adapted developmentally. I put on this slide some examples of topics that parenting support strategies can commonly address. And more recently, compared to 20 years ago, we're much more concerned about the deleterious effects of social media, of overuse of screens in place of personal interaction or academic engagement. But there's also sleep and drug prevention and sexual activity issues, and getting children ready for entering school, and then across ages, building cooperation and pro-sociality. These are all examples, but not meant to be exhaustive of the kind of things that parenting support can address. In terms of how we go about this process, dissemination of population-wide evidence-based parenting support is not what most of us in the social and mental health fields have been trained to do. And it's only in recent 10 to 15 years that these strategies have even begun to be tested. And so here are some of the elements that are critical to it. First of all, no single service sector should monopolize delivery and of parenting support, and definitely not by or primarily by child protective services, which would stigmatize or maybe even scare away parents from gaining parenting support. Rather, evidence-based parenting support needs to be accessible in many locations and sectors, in health centers, public health and social service agencies, community centers and clubs, schools, Head Start, libraries, and even faith-based locations as well, because parenting support is a generic commodity for parents and children. Certainly, digital media compared to, say, 20 or 25 years ago provide valuable assets for broad dissemination. But it can also be misleading if those digital sources are not evidence-based, but are based on somebody's either financial interests or their personal biases about what they think parents should do. Then we want to draw on a whole variety of workers and disciplines that need to be engaged. Accordingly, two large research needs for NIH and other research agencies to invest in. One would be developing and testing of efficient systems for population-wide implementation. So there's a lot of talk about that, but there's relatively little research actually being conducted on the systems themselves and improving system-wide implementation. And secondly, to look at the impact of these kinds of systems on prevalence rates for both adverse and healthy outcomes. Finally, let me mention return on investment. Not surprisingly, the prevention impact of population-wide parenting support points to great potential for financial return on investment, more so than individualized programming. Two points I'll emphasize in trying to optimize return on investment. One is that the parenting support strategies need to be truly efficacious. They need to have gone through testing rather than being speculative or idiosyncratic. Because just because we want something to have an effect and then have a return on investment doesn't demonstrate that or prove that we should invest. So the evidence base is critical, but it's not sufficient. You need also ways to reach larger portions of the population and benefit larger portions of parents. And so a second goal is to have multiple targets from the same parenting support intervention. For example, it is quite possible for a parenting support strategy aimed at reducing risk for child maltreatment, child abuse and neglect, to also be able, with the same intervention, to promote child readiness for school entry. And if disseminated to large numbers of parents of young children, then you don't have to single out parents who are at absolutely the greatest risk for child maltreatment. You can broaden the net and show impact for both groups. So to wrap up, my assumption is prevention is a structural choice, not an individual responsibility. It is something that we have to deliberately design and put into practice. In that spirit, I'm going to mention that this isn't just a U.S. problem. It's a global problem. Many nations are searching for effective policy in the parenting sphere. And I wanted to point out to you coming up next year, it happens every 2 years, the International Congress on Evidence-Based Parenting Support. A lot of U.S., but also 20 to 25 countries participate in this. and it's an online thing, so you don't have to travel abroad to partake of it. Thank you for your time.
Thank you. Thank you so much, Ron. That was amazing. Thank you for drilling down into what we discussed with NIH and what it actually means and looks like, and some cautionary statements and the how-tos and the structural nature of prevention. So thank you so much for setting us up here. I would just wanted to let you know quickly how people responded to our last question about what it looks like for children in 2036 if the Decade of the Child initiative is implemented. And folks said universal child care, access to basic needs, health care, healthy, happy, resilient children in mind, body, and spirit, fruitful prevention outcomes, and then a survey of youth so that they can see their own future being bright, more joy, fun, art, beauty, multi-generational play. I love all of that. So I'm going to introduce Dr. Tony Biglin. Where are you? Tony, can you come on video?
I have a thing that says start my video. Should I click on that?
Yes, please. So Dr. Biglin is a senior scientist at the Oregon Research Institute and the director of Values to Action. He is also a member of the Decade of the Child Committee. And so he's going to sit there while I play a video for all of you to watch. So let me share my screen again. Hopefully that is coming through. I will keep my eyes on chat and my text. So tell me if you can hear this or if you can't hear it. Here we go.
Thanks for the opportunity to talk at this very important event. I want to talk about family income and the role that that plays in the problems we have in society. Denny Fishbein and Ron Prince and I published a paper over a year ago on a comprehensive framework for understanding health inequities and disparities. We started by talking about the ultimate outcomes of any public health effort, or the prevalence of disability should be reduced and the incidence of premature death should be reduced. And we talked about the fact that physiological stress processes and risk factors are key influences on these outcomes. And in fact, the risk factors are pretty well established. And in fact, there's been considerable research on how we can do interventions that reduce those risk factors, that reduce hypertension, tobacco use, dietary risk, and so on. And so the prevention science movement and the public health movement has made some significant progress there. But at the same time, there are social and structural determinants of health that account for disparities and contribute to premature death. And we argued that problems such as poverty, discrimination, harmful marketing, toxic physical environments, diminished quality of schools and neighborhoods, and inadequate access to healthcare are all risk factors that also need to be addressed. And I would argue that the prevention research that has been done has tended to focus more on the more proximal risk factors, and we paid less attention to these social determinants which need attention. But there's one more thought on that, and that is that public policy is one of the major influences on these problems, on these social determinants of health. And so not only do we need to be concerned with how we can prevent or change the social determinants of health, we need to understand the public policies that affect these social determinants and what can be done about it. And that's what I want to talk about today. To begin with, family poverty is the main thing I want to focus on here. It's a powerful risk factor. It's a risk factor for child abuse and neglect, for family stress, for developmental delays, for school readiness problems, for anxiety and depression, antisocial behavior and delinquency, substance use, premature mortality, school dropout, chronic health problems. Family poverty is such a a key risk factor that we need to put a lot of effort into reducing family poverty. And I would also point out that child poverty in the US is much higher than it is in most countries. That red bar is the United States. 26.2% of children are living in poverty. And by the way, the poverty criterion is woefully too low. But in any case, child poverty rate is higher than virtually all of the economically developed countries. We're not quite number one, but we're pretty close. I published a book a couple of years ago called Rebooting Capitalism, and it recounts the 50-year evolution of a government that serves the interests of the wealthy. And you're probably familiar with this, but let me just remind you of a couple things. I would cite Milton Friedman's New York Times essay on September 13th, 1970, in which he argued that the only social responsibility of business is to increase its profits. And that had a huge impact in promoting the view of wealthy businessmen that corporations should simply focus on in maximizing their profits. And so here's what happened over the last 50 years. This top darker line is a measure of productivity of the working class. And the second one is the income, the annual growth in income. And what you see is that coming out of the progressive era and the New Deal, that we had increases in income and increases in productivity. But what happened starting in the late 1960s and later on is that the productivity kept going up and up and up, but the income stagnated. And so by 2020, you see this huge gap. These workers were being more productive, but they were getting less funding. And so what happened is that the US wealth share of the top 1% soared, as you can see in this. But the bottom 50%, it actually declined. We have a country that has very high levels of poverty, and we have created that by the policies that we allowed to become dominant in this country. And then there's economic inequality, which is an interesting problem. This set of things on the left are all measures of some sort of social problem. And it turns out that if you have an index, as Wilkinson and Pickett did, an index of all of these problems, and you run that up against the economic inequality, and there's a very significant relationship. The greater the inequality, the greater these problems. And interestingly, by the way, it turns out that wealthy people in countries that have high levels of economic inequality actually do less well than wealthy people in countries where there isn't such a discrepancy. And the reason seems to be that in an unequal society, people are constantly running into other people who are either above them or below them, and it causes social friction. And Wilkinson and Pickett have shown that. And guess what? The US has the highest level of economic inequality. We're number one. And so this is a risk factor, and it's a risk factor that is distinguishable from poverty, and it's something that we should be concerned about. And so what can you do? First of all, let me make the point that increasing family income will benefit children. There'll be healthier births, there'll be better cognitive and academic outcomes for the kids, there'll be better behavior and mental health for the kids. Higher family income will also contribute to more parental investment in the family and better long-term outcomes. And there's evidence of this both from randomized trials and from natural experiments and studies of the impact of unconditional income transfers. So we have a host of studies that show that when you increase the family income, you get positive results. So in sum, reducing family poverty should be one of the highest priorities for prevention science and public health. So turns out that there are significant ways to increase family income. I could go on because we've been studying this, but I'm just going to list them. First of all, you can help families claim money that they're already owed, such as the child tax credit, the earned income tax credit, and free tax preparation, and so on. And there are communities that are making significant progress in ensuring that everybody who's eligible for those benefits gets them. You can also increase earnings from work, worker protections that make sure that they get the pay that they're deserved, and to increase paid leave. And we can reduce major household costs like childcare and housing and transportation and healthcare, which have gone way up in terms of their costs. And these are reasons why I say that the standard for what counts as health overlooks the huge inflation that there's been on many things that were not even considered in defining what we would call poverty. And then there's providing direct cash or income supplements, guaranteed income, emergency cash, and child allowances all have benefit. And we need to build pathways to better jobs and wealth, and the unions, and the fact that policies over the last 40 years have made it harder for unions to be organized, and that has contributed to the drop in income. So what we need now is, one of the things we could use is research on how to implement effective strategies in communities. So the question is no longer what works, it's how communities can organize, implement, and sustain what works. And Values to Action, my group, is working on that issue. And the way we do that is we build coalitions to study how local coalitions can bring together schools, health systems, and so on to increase the income of families. We could test the training, coaching, and data systems and leadership supports that help communities deliver proven strategies. This is an under-researched issue, is how you help communities organize around these things to support the implementation of effective policies. And we need to adapt to local contexts, examine how effective strategies can be tailored to local cultures, needs, and resources without losing its impact. And we need to measure community impact. We need to track changes in family income, child poverty, school success, behavior problems, and well-being over time. So the next frontier in community implementation research would be experiments that test how communities can organize to put effective strategies into action at scale and sustain them over time. And this is one of the things that we think is badly needed. And also, I wanted to mention that expanding the child tax credit significantly helps children. And this is an interesting point to make, because we had a natural experiment in 2021. There was a fully refundable child tax credit implemented, and it was up to $3,600 per child under 6, and $3,000 per child ages 6 to 17. And the immediate benefits were food insufficiency was reduced in the homes that got this extra cash. Families used payments mainly for food, housing, and child-related needs. And the studies found little evidence of reduced employment. But then it came that for some strange reason, it was decided that this would be done for a year and it would be renewed in the next year. Well, when it came time to renew it, there were 2 votes short in the Senate, and it wasn't renewed. And so we had a natural experiment. And guess what? Child poverty more than doubled as a result. And children were harmed by this. And so it points to the need to have better policies. There was a very important paper published by the National Academy of Science that summarized all of the ways in which family income could be increased. And a group of people that I was working with decided that we would write something on strengthening family well-being, and we published the paper about 6 years ago. And I reread that paper in preparing for this. And what struck me was that we summarized what the National Academy had found and emphasized it, and We said, these are the things that need to be done, and wrote it up like, oh, well, we've done our job. We told people what was needed and so on. And nothing has happened. And believe me, I have years of experience. It is a pretty weak intervention. And so I want to talk about that in terms of its implications. And that brings us to the decade of the child. And this is the brainchild of Denny Fishbein and others. So the evidence is clear, and this is their argument. The evidence is clear. Poverty, trauma, school failure, harmful environments undermine child development. The child tax credit showed that child poverty can fall rapidly when policy acts. Fragmented programs are not enough. Children need coordinated supports. The missing ingredient is sustained, organized cross-section action. And the 5 pillars of the decade of the child would be to focus on family economic security, nurturing early childhood, school as nurturing environments, prevention of trauma and harmful exposures, and the community implementation and accountability. And so my view is that this is what we need, and it really needs to be part of a social movement. So let me close with this. Every major advance in American life has begun with people deciding that conditions they had tolerated for too long were no longer acceptable. Abolitionists said that human beings could not be owned. The labor movement said working people deserved dignity, safety, and a living wage. The women's movement said half the population could no longer be denied full participation. The civil rights movement said the promise of the Constitution had to apply to everyone. Disability rights advocates said people must not be excluded because society was not designed with them in mind. The environmental movement said clean air, clean water, and a livable planet were not luxuries. The tobacco control movement said powerful industries could not be allowed to profit by addicting and killing people. In every case, the goals seemed too ambitious at first. People were told that the problem was too big, too complicated, too expensive, too political, or too unrealistic. And in every case, progress came because ordinary people, joined by scientists and advocates, parents, teachers, clergy, nurses, doctors, organizers, lawyers, public servants, and community leaders, refused to accept that the world needed to be as it was. The decade of the child can draw strength from that same American tradition. It does not ask us to start from nothing. It asks us to gather the wisdom, courage, and science and moral energy already present in this country and focus them on one clear purpose, ensuring that every child grows up with the conditions needed for health, learning, safety, belonging, and opportunity. We know enough to act. We know what harms children, and we know what helps them. The question is not whether we have enough evidence. The question is whether we have enough commitment. A decade of the child would be our answer. It would say that children's well-being is not one issue among many. It is the test of whether we are building a decent society. It would bring prevention science out of journals and into the neighborhoods, and it would make the purpose of policy not merely to manage suffering, but to create the conditions in which children and families can thrive. If earlier generations could abolish slavery, expand democracy, reduce smoking, clean the air, protect workers, and advance civil rights, then surely this generation can commit itself to nurturing every child. And for more information about the growing social movement, I invite you to go to the Nurturing Nation Substack, and here's a QR code. Thanks for listening.
I'm going to let that sit for a minute while I just say, I would say there are just no words to follow that, Tony, but it's quite the opposite. There are words. There are
Thanks
words.
for the opportunity to talk at this very important event.
Yeah. And we
want to talk about family income.
Sorry about that. Yeah, that was really moving, mobilizing, motivating, and just crucially important with that very compelling evidence of where our investments need to be. Thank you so much, Tony.
Yeah, if I could
Yeah.
just say, uh, if people are interested in this, we have a lot of opportunities to try and promote the changes that are needed. And which, if you go to that Substack essay, you'll get. We're just trying to build a movement. We've got about 120 people who've subscribed. We're aiming for 1,000. So thanks for the opportunity to talk about it.
Many thousands. Thank you so much again. So hang in there with us, folks. Thank you so much. I know it's been a long day, but just so packed with information. Hopefully that has energized you and not exhausted you. We have a few more speakers. We're going to continue with this solution-based problem-solving approach this afternoon. And so we have a lot more to present here. I'm going to send that back to Maddie to introduce our next speaker. Thank you.
Yeah, thank you. And thank you, Dr. Biglin, for your talk. Next, we will hear from Dr. William Wojciorek, who is the CEO of the Pacific Institute for Research and Evaluation, as well as a member of the Decade of the Child Committee.
Thank you so much, Maddie. Let me get my screen shared here. And oops, there we go. Let me get this guy right up and from the beginning. And so it's a real challenge to follow Tony, but it's an honor and a privilege to do so. What I'm going to be talking about is really going from, instead of the big picture of that was just presented by Tony and all the other views we had, really thinking about how you take this prevention-centered policy and research framework about high-impact federal investments in whole child health and really align it to the centrality of what this would look like within an NIH type of orientation. So the whole child policy framework, and we've been talking very much about policies all day long here. But where we start is that we're totally focused on whole child well-being, all aspects of development, all aspects of life, all aspects of being, a human being. And that where current challenges and our disparities are especially large in chronic disease. We have in the United States, there is no doubt, we have a child well-being crisis. We compare terribly to all of our other peer types of countries. What I'm talking about too, that goes with the whole child policy framework and some of the role of especially NIH is about a policy alignment and that orientation towards prevention. And especially the role of the NIH types of priorities, as well as MAHA strategies can be aligned around improving prevention, improving well-being, reducing disparities. And one of the key aspects of this is how do we get system level alignment by defining outcomes, identifying barriers, aligning levers, and building accountability. And I like to use the term accountability because what we're talking about here at all levels is what do we do from a policy perspective? How do we shepherd public resources that are given to us, both from a policy perspective as funding for programs and people, as well as the resources that are spent within NIH to support the type of research framework that we can use. And this alignment is the largest challenge for this type of investment. I mean, it's about aligning systems, and system alignment is a huge challenge. Moving from evidence to implementation to aligning policy, care, supports, financing. And we know many of these problems. We have fragmented systems. Research remains siloed across agencies as well as all of the types of supports. We have an implementation gap. We know what works, but we don't know how to scale up truly what works, especially in effective and multi-level types of implementations. There's a measurement gap that's been talked about. Outcomes need to be tracked more consistently than they are. And this is an orientation that NIH has that we should be able to build on. And there's a policy gap. Non-medical policies remain understudied as health interventions, and we know that they have major influences. Moving from a reactive, more treatment-oriented to a life course prevention orientation is what this alignment is all about. The federal research agenda should help accelerate this type of systematic transition. And we know these. I'll go through them relatively quickly. Right now, we're much more downstream treatment orientation rather than upstream root cause prevention. We have program by program fragmentation instead of integrated cross-sector systems. We have short-term budget orientation. Who hasn't been involved in hearing, oh, we had this grant that worked well for 4 years. It ended. It had impacts. And instead of looking at intergenerational return on investment and its impact on life course outcomes, we say the money went away. So even if there's a multiple $3, $4 to one in savings, we're still not doing the things that we should be doing. We have limited feedback on child outcomes. We need real world data, accountability, and systems that bring all of those together. That's why a central tenet of how we're, especially today, and focusing the decade of the child is about a trans NIH across institutes, centers, and offices approach to whole child research. Child well-being is much larger than any single institute. And the institutes were all formed for a number of reasons, and many of them are really disease specific. And that makes it a challenge to have whole child, whole well-being be the focus. So there needs to be not just coordination, but truly a trans NIH level of coordination across the ICOs that integrate funds across the institutes as well as within institutes to translate evidence into systems level types of changes. Integrated research domains, mechanisms, biology, genetics, epigenetic processes, context, social, environmental, structural drivers. And I want to mention, I guess I'll mention environment and context multiple times. We talk about environment. Environment includes policies. Environment includes social environment as well as physical environment. And the timing, when things happen, matter a whole lot. And the policy impact. To truly using an NIH gold standard research approach to bring in policy to the research that we're doing on these multi-level kinds of approaches to prevention, with the end state of scalable prevention science that improves whole child health. Align what we are, what we study, when, where, and how it changes whole child health. And we've heard from some of the NIH leadership about NIH investment tracks and from previous presentations. There's room for discovery. We still need more discovery in what we need to know. We know a lot about what does work, but we still need to know about more in how it can be integrated from basic bench and biological sciences as well as behavioral sciences and sociocultural sciences to be able to better refine our evidence, develop new programs, as well as implementation and dissemination. These are the things every time we implement something, it's a new implementation. It's done by different people, different times, different locations, and we need to study how we scale across populations and contexts. And again, that focus on policy, evaluate policies as health interventions, really bring them in. We have modest research that builds there, but if we're going to build this in a strong way, we need to integrate it. So we're moving from single interventions to multi-level prevention and health promotion interventions for children. Not surprisingly, in a country that has tremendous, especially chronic disease issues, and has some of the worst child outcomes that we can imagine on the entire planet, there's a movement that's focused on bringing attention to these issues. And the MAHA, Making America Healthy Again orientation, truly does overlap with many of the issues and topics we're talking about. Root cause drivers, nutritional systems, environmental health. Again, much of the focus sometimes on reducing toxics and cumulative exposure, but it's also cumulative exposure to both physical and sociocultural types of environments, traumas, ACEs, family context. We've heard so much about family as the strength orientation to really build child well-being and early life exposure, targeting, timing, risk matters. And it's a cumulative risk science. Allostatic load is the opposite of homeostasis. How many bad things pile up and they have an impact? We need to better understand, bring those together so that we can alter life course trajectories and reduce chronic disease risk. And all of this can be focused on disparities. Another thing, when I talk about disparities, we have the NIH populations that we know experience disparities, as well as the United States itself is a disparity when it comes to the rest of our peer nations of how we look at and what we're accomplishing with our child well-being. So we need to do this by identifying the combinations of these exposures reduction, prevention orientations, and to change life course trajectories. Now, an aspect of it, and so especially when it comes to policies, we sometimes study some of the major main effects. And because they're understudied, we're barely getting the tip of the iceberg on that. But we really need to understand interaction effects, not just isolated causes. We need to fund studies that truly interact between biology, environment, and policies, as well as timing. As you go through the research priorities there on the left, they need to be longitudinal, multi-level, focusing on those sensitive periods, early life, childhood, adolescence, and the transitions across these with linked pathways with the context of the biology. Also, want to say biology includes all of our organ systems as well as genetics. And that's why in that center interaction, it's about that biology, environment and its complexity, and that development over time, where it's gene by environment by development, that really can help us understand these measured biological processes that lead to health outcomes. So we prioritize interaction effects, not because we're not interested in main effects, we want those, but the interaction effects explain the when and the how and the context for whom that we can alter these childhood transitions. Now, we also need NIH-supported longitudinal measurement architecture. We have some measurement in place. We've heard about that today. We've also heard from some of the NIH leadership that this is a priority of bringing this together. Many of these data systems are not within fully the purview of NIH. However, they are from the perspective of NIH has the mission to support health and in a centrality for an orientation such as the Decade of the Child to help bring together these various outcome domains so that we can look at life course evidence by linking cross-sector data to track life course outcomes. And you can use these to run rapid cycle evaluations as well as, again, disaggregate disparities. We need to know main effects, but main effects often mask some issues where effectiveness is more limited, quite frankly. So again, accountability, like use the term accountability because we are accountable to ourselves, we're accountable to the population, to the standard taxpayers for NIH longitudinal research that links data, disaggregates outcome, and that we get past one-time metrics. And we're doing this within a variety of implementation platforms. It's an integrated child-serving ecosystem. Not all research is going to be able to integrate all of these. Again, we've heard multiple times. There's various platforms to be able to deliver systems, and we need research and orientation that helps bring these together. And so there's shared goals, warm handoff between systems, shared data, and a continuous learning across all of these implementation platforms. But we know that implementation is never uniform. Going back to mention that earlier, we know that context varies by a tremendous number of variables, population, social context, time, environmental, policy. We need to do pragmatic trials. Pragmatic trials are difficult. Because it's a messy world, and we deserve to do good science in the messy world we actually live in, so that we can do effective adaptation and with fidelity, and implementation mechanisms. Which ones are going to be important for readiness, as well as how this actually works in a complex system? Again, a focus on disparity reduction. In studying policies, there's many complex ways to study policy, so I'm providing just some overview of some of these ways. But economic supports, we heard from Tony much about this. These are natural experiments in which we can look at health and development outcomes. We need support. NIH gold standard science needs to be oriented to incorporating policies in the work we do. School policies, environmental policies. There's an entire range of going about utilizing these. Is pure policy analysis oriented towards health, as well as integrating in with our multi-level prevention programming and interventions. There's substantive levers, and we've heard about these on policy. Make children visible. Various ways of doing that. I'll summarize it by that last statement. Child health in all policies. What's that look like a policy? Another step back. We talk about policies, though we're looking at the federal resources to be able to drive this from a research perspective. We have policy on the local and especially the state level, as well as the federal level, that needs to be integrated in this orientation. It provides many opportunities for following us. Finance and how we finance prevention, whether it be pediatric models, tax credits, continuous coverage, paid leave for strengthening environments. Measure accountability. Again, linking these outcomes, disaggregate the gains, rapid cycle learning, policy main effects and interactions over time. Again, the principle is identify the levers that create measurable child well-being gains and for whom. And the prevention financing is a whole set of additional policies to be examined that sometimes are in some systems, but again, need to be brought into the NIH world of rigorous gold standard science. What does continuous coverage truly look like and achieve? What do those prevention inputs interact? The pediatric payment models, a population-based model, disparity lens instead of payment for service. Again, the outcomes, looking at chronic disease risk, and why I mention obesity. We lead the world in one area very clearly in child issues when it comes to risk, and obesity is that. So we need to have milestones. We know that mental health is a through line that goes through all types of health and well-being, through childhood, through across the entire lifespan. So which payment, coverage, policy models produce these measurable life course gains, and for which children, and under what types of implementation conditions? And so we have a disparity prevention model where we need to close the gaps. Are the gaps narrowing? Focus on high burden communities. Partner, co-design with affected communities. Track by age, sex, race, context, exposure burden, and then close that gap by adapting and adopting before the gaps widen. We have wide gaps. We can make a tremendous impact with this type of orientation for a decade of the child. Earlier prevention and narrow disparity gaps. Use the evidence to adjust and respond to do that. And NIH research can drive that. A federal policy roadmap as well as state, make children visible, the child impact statements, shared well-being metrics, stabilize access, build delivery platform systems. You looked at that ecosystem, reduce root causes and govern for the outcomes, link data, disparity tracking, rapid cycle learning, sharing across the systems. Again, which policies measurably improve life course outcomes and for whom? Now, as you look at this, it's a 10-year orientation. And these are gross generalizations about the time, but we need to think about if we're proposing this, what it would look like. In the first few years, you're aligning and measuring. By aligning, what are we lining across and within in a trans ICO NIH orientation? How do you even start to build teams? Because we're talking about research that's much broader than areas that we've looked at before. We're looking at years of then years 2 and 3 to starting to really start to test these combinations, evaluate coverage, exposure, reduction policies all together. Scale this implementation, run those pragmatic, tough to do trials, study workforce. I want to step back. Why you have fewer pragmatic trials? We need an orientation to it. When you're working in real world integrating policies with programs, you have a lot more issues that can go wrong with your studies. We need to purposely want to apply our efforts to this. And then years 5 through 10 are really taking what's been learned and built during years especially 1 through 5 or 6, to account for these impacts, to really flesh out this type of research orientation. So the finish here is a call for action. Child well-being is a national prevention. Whole child well-being is a national prevention strategy. An NIH Decade of the Child and a trans NIH roadmap for whole child well-being is essentially getting a healthier child. We need to align the funding. We need to measure outcomes. We need to scale prevention, and we need to assess policies. And I'll leave with this last sentence. Healthier children, stronger families, lower lifelong burden is not an option. It's a national imperative aligned with key NIH priorities, such as chronic disease prevention, population level outcomes, reproducibility, real world data, women's health, and gold standard science. Thank you. And
Thank you so much, Dr. Wigzorek. Now we will hear from Dr. Margaret Kuklinski. Dr. Kuklinski is an endowed professor of prevention and social work. She is also the director of the Social Development Research Group in the School of Social Work at University of Washington. Dr. Kuklinski is also a member of the Decade of the Child Committee.
Hello, everybody. Thank you for that introduction, Maddie. And I just want to make sure you can see my slides. Everything looking good? Okay, all right. I'm going to move the speaker panel a little bit, excuse me. Okay, so again, thank you everybody for being here. It has been a rich day and it has been a long day, and I appreciate your attention as we turn to opportunities to transform whole child health at a population level through scalable solutions. So achieving that population level impact will continue a theme from this afternoon. We're really keeping our focus a little bit away from specific programs and practices that work for whole child health and thinking about what is needed to scale those strategies so that we can get that whole child health and flourishing at a population level. It is late in the day, so I thought I would start with some bottom lines from this presentation. And the first is that we actually have models for scaling strategies that work for whole child health. And I'll share one of them in a moment. And then we also have effective, evidence-based, local and state examples of scaling in those geographies. And those are going to be the heart of this presentation, and I'm focusing on those because I want to share examples of things that can work to scale what we already know works. And then I want to close with a forward-looking message about a pragmatic research agenda centered on what we need to ensure that more children, families, and communities benefit from what we already know works. A pragmatic research agenda is a way to do that. So in a series of consensus studies that date back to 1994 and trace the field of prevention, the National Academies has spotlighted the importance of upstream solutions to health and well-being. The 1994 report was early in the field and focused on risk and protective factors and the relationship to mental disorders. By 2009, the field had evolved and there were evidence-based strategies, programs, practices, and policies that could influence mental disorders and other outcomes for young people. So the 2009 report spotlighted those. By 2019, the report was going even further, focusing not only on the evidence-based strategies, but also on the implementation factors that had such an influence and were so important to attend to if we wanted to reach those goals of population-level outcomes. The 2025 report, of which I was a member, went further still. It took a systemic approach, laying out a conceptual model of the infrastructure needed to scale those strategies. I want to say a little bit more about that model. It's a foundation for some of the other things I'll say throughout this talk. So I want to also recognize our funders for this study, who are the Centers for Disease Control, the National Institutes of Health, and the Substance Abuse and Mental Health Services Administration. So the report's premise is that more resources and a stronger infrastructure not only can yield, but really are essential to achieving that goal of better health and well-being at scale. This figure represents the infrastructure that our consensus panel concluded is essential to adequately delivering those upstream strategies and ensuring mental, emotional, and behavioral health and well-being. This infrastructure model applies to all ages of the developmental continuum, but especially to children, and it also includes policies that are so important because they can reach so many children at once. The strategies are delivered by the systems you see at the top of the screen, and throughout the report, the consensus panel also attended to the importance of health equity for all and to that implementation science perspective that again was so important in getting those effective strategies to have impact in real world implementation. So the report included a number of recommendations for enhancing each of these elements. You can access the report using the QR code at the lower right of the slide. But the overall message is that these elements work together. They are synergistic. We need funding, governance, and policies that support the use of evidence-based strategies at a population level that are carried out by a highly skilled workforce and use data to identify strengths and needs and monitor the results of scaled strategies. And I will add that that process also includes building the evidence to fill in gaps, as is sometimes the case, or especially the case for some of our high-need communities. So it's a flexible framework, but those pieces together, the committee concluded, are the ones that are needed to really ensure that we have a strong and robust infrastructure supporting the scaling of those upstream strategies. We do have evidence at the local and state levels that when these elements are in place, young people do better. And I want to share those examples now. So at a local level, Communities That Care is an evidence-based framework that builds local infrastructure for prevention and health promotion. And it's had impact that I'll tell you about in a moment. But for a while, I want to focus on the process, because CTC is a flexible process that can be applied not only to the outcomes that it's been studied in relation to, but really to a number of different priorities that local communities might have. So some important things to know about CTC. It assists communities in selecting and implementing multiple strategies, not just a single program or practice or policy. And that's important because the overall goal is to reach all young people in the community at the level of intensity that they need. It's also important to know that the work is carried out by a local coalition. They are the drivers, they are the decision makers, and this is an example of what Nora Volko referred to earlier today as democratizing science. What CTC does is provide a step-by-step process so that communities don't get stuck in this work that is multi-sectoral, that aims to be comprehensive and coordinated, and that is really challenging. So CTC is implemented in 5 phases that map onto the Blueprints model. Governance and funding are the focus of phase 1 and phase 2. Key leader support is critical because not only do they have resources at hand, but they also have influence and can generate support for CTC. Governance is in the hands of the local coalition that, as I mentioned, drives the work. Data are used in phases 3 and 4 to identify strengths and concerns and set priorities and then select strategies to achieve those priorities. And while CTC focuses on evidence-based strategies, it is certainly the case that in communities these days, it's a mix of strategies that are important. There are often strategies that aren't fully evidence-based, but that a community knows are effective with the people in their community, and that's perfectly acceptable as part of the work. So data form the basis of that plan and the priorities and the strategy selection, and then a skilled workforce is essential to implementing it in phase 5, and then again data to monitor the results. That implementation focus is also built in because there are milestones and benchmarks to support progress in each of those phases. This slide highlights the change process that occurs in the community. What is it that happens? Well, the CTC framework builds skills and capacities in the local coalition, and it's those things that transform how prevention occurs in the community. It becomes more science-based, more collaborative. There's more support for prevention. And it's those things that really lead to achieving the goals of the coalition for positive youth outcomes, whatever that may mean in that community. We do have evidence for each element of this theory of change, and we also have evidence for the impact of the model on young people's health and well-being. And that does not just come from our own work. It comes from 3 other independent quasi-experimental studies conducted at very diverse locations, including outside of the United States and also in urban communities. But overall, CTC supports scaling. When the framework is used, more strategies are implemented and more children and families are reached. And those things lead to population level improvements. And by that, I'm referring to community-wide improvements in behavioral health outcomes. And there are a number of them that CTC has affected across these trials. And that's because CTC focuses on the upstream risk and protective factors that are shared by these outcomes. We and others who have studied CTC through those quasi-experimental trials have found that the improvements that were found in adolescents endured over time into young adulthood. And this was a while after those young people were exposed to upstream interventions. So we have robust evidence that CTC works. We also have evidence that it's cost effective. It's a good investment of limited resources. We know that from work performed by the Washington State Institute for Public Policy and also from our own and from our Australian colleagues who also showed that CTC is cost effective in the Australian context. But pulling back, the idea here is that CTC provides a process to support the development of strong local infrastructure for upstream strategies. Implementation support is very important to those communities who are doing that work, and the process is flexible and can be applied to outcomes other than those that we have already studied. Our center does support communities in the United States and internationally in implementing CTC. And I wanted to share here a quote from one of our community coordinators that speaks to the benefits that they have found in doing the work when supported by our coaches. It's not just at the local level that we have examples of effective infrastructure development systems. We have a great example of strong state capacity and infrastructure for upstream preventive interventions, and that is from Washington State, where Sarah Mariani and her team of the Division of Behavioral Health and Recovery have been doing evidence-based prevention for a long time now and progressively developing a stronger and stronger system. So their local model is called the Community Prevention Wellness Initiative. It is an adaptation of CTC and the Strategic Prevention Framework to fit their state context, and it operates in over 90 communities across the state. With a focus on health equity for all, the state's investments, given limited resources, are generally on higher need communities. Those communities are identified through a community risk index, the results of which are shown on the slide to the right. And it's the purple, blue, and bright green areas that show where risk in the state is higher for young people, either for substance use, for mental health concerns, or both. And it's those places where the CPWI initiative is focused. Those CPWI coalitions do use data to set priorities and select strategies, and routine monitoring and evaluation are built into the process. I want to say a little bit more about how this infrastructure that Sarah Mariani's team has developed fits with the blueprint model. So I'll just briefly touch on these things here, and I have some other slides to say a little bit more about them. So governance, of course, is with DBHR. For funding, Sarah is a master at braiding block grant funding with funding from other sources. Data, you've seen some of it. I'll share the Washington State Healthy Youth Survey data in a couple of slides. There's support for picking evidence-based strategies and for the workforce. And one important thing to say from a policy perspective that affects how prevention is done in Washington State is that their minimum allocation to prevention is 30%. This is 50% higher than the federal minimum allocation of 20% of block grant funding. So that right there strengthens support for prevention. And I mentioned the health equity for all focus on the prior slide. The CPWI work, Community Prevention Wellness Initiative work, is part of a larger, robust system of partnerships that foster upstream approaches. Those approaches are described in a 5-year strategic plan that shows some of the players and also is guided by a logic model. Data, I mentioned, are very important in the Washington State, both decision-making and monitoring context. And that includes the Washington State Healthy Youth Survey, which is administered every 2 years to students in grades 6, 8, 10, and 12 across the state. That in that survey, young people report on risk, protection, and behavior, and support for completing this survey is growing, including the last survey in 2025, in which over 200,000 students from all of Washington's counties participated. It is a wonderful source of data to understand the prevalence of and trends in health risking behaviors, and also strengths from young people's perspectives. It's used in policy formation and priority setting, and also in research. As I mentioned, communities in the CPWI initiative choose evidence-based strategies based on data. To support their choices, there is a Washington State Excellence in Prevention Strategy Guide, where programs go through a robust review process before being added to the list of things that local CPWI coalitions can choose to implement. And there's also attention to making sure that the prevention workforce is skilled. So right now, the University of Washington Center for Communities That Care and Washington State University are training the prevention workforce in ways that are aligned with SAMHSA's prevention core competencies and also with CTC tools and training. Does all this attention to infrastructure matter? Yes, it does. This approach has been evaluated by Brittany Cooper and her team at Washington State University using propensity methods, and their evaluations have demonstrated both improvements in risk and also improvements in substance use outcomes, as you can see on this slide. This slide shows that the percentage increase in substance use initiation from grades 6 to 12 was much lower in young people from CPWI communities compared to those who are not. And that is shown across 4 different cohorts, and the evaluation is ongoing. Let me just go back for a moment. So I just want to close this portion of the presentation by saying that it is possible, and Washington State has demonstrated that this infrastructure to support the scaling of evidence-based strategies across a state is doable. It is challenging, but it is doable, and it can have impact, as has been shown in Washington. So we have effective models for scaling upstream strategies at local and state levels. Where do we go from here? And I think you've already seen in other talks that there is a desire to have a trans NIH effort institute focused on whole child health. We've seen from other big initiatives how important and impactful such investments can be. I have been part of the Pragmatic Trials Collaboratory. Our study was spotlighted by Dr. Shurtleff a little bit earlier in this presentation. We know that the work that those trans NIH efforts support can accelerate knowledge gains that drive health impact. And in our own work, the learnings have led to new studies to improve outcomes for families through evidence-based prevention in the settings that they frequent, like federally qualified health centers. But we're doing so in a way that reduces some of the barriers that have affected the sustainability of preventive interventions in those settings. So we're picking up where the Guiding Good Choices for Health study left off in aiming to increase the population level impact of effective parenting programs. What if there were a pragmatic research agenda focused on whole child health? Several presenters have talked about this. I do think it's so important that such an agenda include a translational research emphasis, scaling what we already know so that more children can benefit. An implementation science focus is also critically important because we know that it's not just having something that works. We need to make sure that it is fit to context, and we need to understand both the facilitators and the barriers that can support that fit to context happening. Focusing on policy levers is also important to enhance child health and well-being, in particular because those policies can affect so many children at the stroke of a pen. There are many, many questions that could be addressed by such an agenda. Some examples here show how we can address replication, innovation, and sustainability, but always focused on scaling evidence-based strategies to reach more children in a way that is consistent with a whole child focus. I want to close here with a reference to Elizabeth Shore's wonderful book, Within Our Reach, that some of you may remember. It first came out in 1989. She argued, even at that time, that we had the evidence, we knew what to do to break the cycle of disadvantage. And I would simply say that we know so much more today because of NIH and other investments in science. We have both evidence-based strategies and also evidence-based models for scaling strategies that promote child well-being. They are being deployed in some communities and states, but their reach right now is so much less than their promise. And a translational research agenda focused on scaling could dramatically increase the population health impact for children in this country. Thank you so much for your attention to this webinar.
Fantastic.
Thank you so much, Dr. Kuklinski, for these insights. Now we will go ahead and hear from Dr. Charles Bruner, who is a senior fellow at the Center for the Study of Social Policy, as well as the RISE Institute, as well as also being a member of the Decade of the Child Committee.
Okay, well, I'm Charlie Bruner, and I just realized that I've been doing this work for about 50 years now, and I really have seen a lot of advances made. And I reminded myself of this quote from Mo Udall: everything's been said, but not everybody has said it. And I want to try to just really tease out what I think are the high points and takeaway messages. I think we have had a preponderance of information and I think a whole realm of possibilities and directives and understanding of what we do know and then what we need to do in order to implement them. But it can seem pretty complex through all these. And I think that there is a simpler and a more basic message that I will try to incorporate in my presentation. First is, we really have gone beyond the notion that healthcare is medical care. This is not new. Even before I was born, the definition of healthcare is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And over the last 25 years, in particular through the WHO and UNICEF and Healthy People 2020, and a variety of efforts and activities around child health in particular and bright futures, we also have come to not only the realization that child health is that, but that healthy children live in families, environments, and communities that provide them with the opportunity to reach their fullest developmental potential. We are really looking at health as something that is much broader than medical health or medical care alone. And the Making America Healthy Again executive order actually makes this case. Global comparison data demonstrate the health of Americans is on an alarming trajectory that requires immediate action. This concern applies urgently to children, and there's a top priority on children. And we must ensure our health care system promotes health rather than just managing disease. So try to keep this in some context and keep it a little bit simple after all of the great information we're providing is, put at the top, medical care is not health care. And healthcare is that broader field that goes to both medical conditions and health-related conditions. And it plays not the only role, but a very important role in advancing child health. And in fact, the research suggests that non-medical care factors, whether they are called social determinants of health, risk and protective factors, or lifestyle and environment, really constitute the majority impact upon people's overall long-term health. And child developmental trajectories, which we've spoken about a lot, including ACEs, really are a predominant share of that 70% of contribution of non-medical care to people's health. And I loved Denny's slide on protectional uplifts and adversity anchors and how we have to focus on those, really with that emphasis upon, again, with Christy, resilience and flourishing through a relational health approach. And medical care factors do play a role, and we've had a lot of discussion, a lot of great work at NIH really working on child health care a lot from a medical care factor, and genetics and heredity play 10%. When we heard from the first presenters, and then the survey response was on barriers to improving health, one thing I read through all those, and I really noticed that nobody mentioned the lack of know-how that is the problem in directing resources to increasing protectional uplifts and reducing adversity anchors. In fact, people really did acknowledge, we know that. We know it's important, and we have ways that we can achieve it. Maybe not perfectly, and maybe not at scale, and maybe not all over the board, but that we actually know that we can strengthen those protective factors, reduce risk factors, enhance resiliency, support flourishing, and so forth. This is one of another National Academy of Science and Engineering recent reports, 2025, on the state of healthy parenting primary care interventions that I cite, along with, I think we've now heard reference to 8 or 10 NASA reports that have really pointed to the importance of healthy child development from a preventive and developmental health perspective, and cited evidence of programs that can contribute to this. This particular effort organize this according to what happens in the healthcare system, in the primary healthcare practice, in order to improve healthy child development by strengthening protective factors and reducing risk factors. And really said that part of those studies and the research that have shown models for doing so have been in the well child visit itself, in terms of developmental and behavioral screening, in terms of universal promotion activities like Reach Out and Read and Prescription for Play, in terms of redesigned child office visits themselves, in terms of group well child visits, in centering parenting and parent in Dulce, in terms of technology assisted and support approaches for engaging families, Christie's cycle of engagement, small moments, big impact, Vroom, and in terms of training and coaching enhancements that really enable the practices to be more responsive in their clinical settings with the families and kids that come in, like ECHO and mental health consultation. In fact, there have been this plethora of evidence-based programs that really show that you can do this within child health care practice, and it produces results in terms of improved family functioning and improved child development. Coupled with that, there have been a variety of programs that have enhanced care coordination so that there is a way of getting at families' non-medical needs, specifically when there are additional actions. And some of those are around explicit structures of support, referral, and follow-up, probably medical legal partnerships and Help Me Grow are ones who've advanced furthest on that and showed great promise and results in terms of getting those non-medical needs met. But there are also a variety of relational care coordination and sometimes accompaniment of inclusion within the practice setting or as an adjunct to it, workers who can really connect up with and be the go-to forces as far as responding to families and supporting them in their own ideas, and community health workers, doulas, promotors, and family coaches. And the third area is then those additional services and supports when identified that can also do that. Some are often covered and located in primary care, healthy steps, play, read, VIP, family checkup. Some are covered under parent, infant, early childhood mental health services like circles of security, triple P, parent-child interactive therapies. But these are actions on top of what the practice does, or someone who is in that care coordinating role of supporting families, and covered home visiting programs, which vary from the universal, like Family Connects, through the very intensive, like Child First. I wanted to put this up here because there are now literally 50 programs that or more that really have demonstrated their effectiveness in producing improved child health outcomes and improved family support for children that are really there. One of the things that I want to also stress is that virtually all of these programs were started within people in pediatric practice who wanted to do something to respond to social determinants of health and felt that the medical care they were providing was insufficient to help their families. And they were almost all funded outside of the medical care and their reimbursement system. They were funded by grants and supports, but not through the healthcare system, although they showed great promise for healthcare. I put this in red because I've added to my presentation as I went on with things that I gleaned. But I mean, the Decade of the Child really has been presented by several people, and it really is something I think that is an opportunity for vision and focus for all of us, and a way of setting the stage of we have to elevate healthy child development and whole child health to a much greater prominence, both in the healthcare system and in the broader public health system, and in our overall responses from government and communities. But that really is holistic and comprehensive, and everyone has a role. And some of us are advocates and policy experts on this call, and I think one of our charges is to become a bigger and more powerful chorus for these overall actions and public investments, and really say the time is now to use what we know to expand out. For researchers, I think it is really to stress what we already know and move beyond narrow paradigms to holistic approaches. And in this case, randomized controlled trials are not the gold standard model for most of the expansion we want to do. And implementation science and action research and other forms are really more systemic responses are needed. From Congress, it really can play a role in direct investments toward whole child health and moving from these independent small-scale programs to going to scale and to moving out and to making sure that the healthcare system finances those, whether it's fee for service or whether it's a value-based care system. If the system today is not providing any support for that care coordination, if it's not providing any extra time for the practitioner to embody a more whole child approach in the practice, if it's not providing any financing for doing things like Child First or centering pregnancy or any of the variety of programs, the healthcare system has to step up. So there are real areas for doing that work. And in terms of the role of Congress is particularly around prenatal to 5. That's where the majority of the congressional action and funding has been. State governments have to use these federal opportunities to advance financing, and their role is much more in the integrating this into K-12 education supports. And we've heard a lot from NIH, and it's great focus on news research, but I think as well, their research really has to focus on new research on pragmatic and holistic research that goes beyond medical treatment models. And then in terms of candidates, parties, political activists, and voters, I think that this is something that ought to be part of our 2026 and subsequent electoral dialogues and activities. And it's here that I think actually the nonpartisan community can play key roles in elevating this. And I'm doing some of this work under an initiative related to actually Tony Baglin's values to action, which is mine values to votes. In terms of congressional focus, we have all these effective programmatic efforts, and they're the pieces of the puzzle for really moving forward with a whole child health focus. And we're really at the stage of moving beyond the research and the innovative space to getting the early adopters and early majorities. And that means that the healthcare system has to finance this work. And for kids, this means particularly through Medicaid, which serves over half of all children. And it really is making sure that the doors are open and the resources are there so that we're not just telling practitioners to do it because it's a good thing, but to compensate them for doing the extra work around their own office practices and their screening and their care coordination, which takes people and time, and in the additional services. In terms of the NIH, and I put together this slide as saying, I think the NIH has done great research and continues to do great research, but I also think that where we are in terms of a lot of our medical research is like the drunk looking for his wallet around the stop or the lamppost, is we're focusing upon biomedical and disease research, and that's where the vast preponderance of funding goes. And if we're going to improve population health in a meaningful way, we do have to focus upon children, and we do need to have to focus on social determinants research, and we do need to focus on whole child health research. We do need to look at social vulnerable neighborhoods and how we can build those protective factors and those uplifts there. We do need to be able to, in a much more concerted way, strengthen parenting through primary care. We need a child-focused public health research agenda, and not one that primarily doesn't deal with children and their developing futures. And we need an ACEs flourishing research. So I wanted to put those out there. I was really happy to hear about this potential path forward and the whole child health practical and implementation research collaboratory. And I do believe that from the participants on this call and the presenters on their call, there's a lot of knowledge and wisdom to really move quickly in that direction. I would point that it's great that $5 billion of the 40+ billion of NIH goes to child health, but I think that if we're going to really maximize our impact on population health, it needs to be a much greater share. Children represent 22% of the population, 100% of the future, and their trajectories do really affect 50% more of population health. And I also think that when we talk about what we're doing, children with complex medical conditions or in foster care right now represent the lion's share of current child health care spending. And that's necessary, and I'm not talking about doing away with it, but they also represent less than 10% of the child population. And our gains are going to be really on that preventive and developmental side with kids. We need to respond quickly to a whole variety of health conditions from autism to cancer to early onset of overweight and obesity. But we really have to work at that, what Dr. Prinz said around that parenting in that social environment that's conducive to healthy child development. And there's a big opportunity, I think, within NIH to really invest in healthcare and child public health that expands much beyond medical care. And my three just suggestions in that area is one is really focus on implementation, action, research, and hopefully with increased federal financing to enable the scaling up of effective practices. Really tie that to investing in that action research as it goes forward and learning by doing. So the best ways of implementing and moving from the early majority to the mainstream, we really get that down well. The second is whole child research. One of the things with respect to that slide I provided around those three components of whole child health care that are important is many of our interventions are focusing on one element and showing promising results, but putting all those together in a way that is going to reach the majority of kids who need it is going to require elements of putting those into effective healthcare practice and maximizing impacts for healthy development. And that is, I think, a whole other area of research of really going to scale on really comprehensive and, if you will, the models that really can show the greatest gain in population health that we can then use to adapt and build out. And finally, in terms of doing work in neighborhood and community level research, looking at the most socially vulnerable neighborhoods and recognizing that they're rich in children and they're where a preponderance of our disparities in terms of inequities exist, is we have to find a better way of working there. So I think that the Decade of the Child is a good organizing rubric, but I think that we really have to recognize their roles for all of us, and it's really pushing forward towards action. So I wanted to share that with you. If you want more information about the specific programs I mentioned, the evidence-based building blocks, I think we have a very comprehensive array of things that we've shown do work, and now our role is to expand them out so that they work for all kids and that they work together. And federal health role in health policy requires an investment focus is really a short piece I did several years ago with Maxine Hayes that I think says this is where the greatest opportunities for advancement are. And I think it is probably a good segue to our next speaker, who's going to talk about returns on investment.
Thank you so much, Charlie. That was great. That was great. Maddie?
Yeah, thank you so much. Now that we've heard from Dr. Bruner about how we understand health and health research, we'll hear from Mr. Jesse Kohler, who is a doctoral student at the University of Pennsylvania, the CEO of the Change Campaign, and a member of the Decade of the Child Committee.
Appreciate it very much. It's awesome to hear everything that's been said. I continue to learn every time that I'm with my colleagues here and appreciate very much the opportunity to be a part of this and speak with you all today. I know that I'm sort of closing us out before Denny officially closes us out, so I'll try to bring as much energy as possible. But just start with what I think has been woven throughout the whole day, that community is medicine, right? Throughout human history, our ability to band together and cooperate has always been key to surviving, adapting, and remaining healthy and resilient. And it is together that we have gotten through crises and solved complex challenges. And while this may just sound like a nice talking point, there really is an abundance of evidence that we will get into that proves this to be true. As a country, we are nearing $40 trillion in debt, and most people truly think that there is no way beyond this burden and crisis and multiple crises, the poly crisis that we face. But the presentations that we've heard throughout the day have outlined strategies that we can implement that promote well-being in current and future generations. Right. And I hope to articulate both novel strategies as well as the business case for government to see the necessity to implement and integrate these strategies together. Because the decade of the child is not just something we should do to support healthier children and the strongest society possible in the future, though it is definitely that, but it is also a strategic effort to reduce our debt burdens by strengthening our nation long into the future. The costs of the policies and programs that have been shared today pale in comparison to the cost of doing nothing, which is the name of a research paper with an actual economic model that you can go measure these claims if you so choose to. We need to look no further to prove this than adverse childhood experiences or ACEs that have been brought up a number of times today. Recent analysis estimates the annual cost of ACEs in the United States at $14.1 trillion every single year. This is not a statement on health just at the micro level. We are talking about well-being, or the lack thereof, of our society at large. We know that ACE prevalence has risen across generations. Just slowing down the current rate of accelerating ACE prevalence, as Burfus data indicates a rise of 0.24 across generation, would have a massive return on investment, let alone reducing ACE prevalence in its entirety. And that return on investment will compound exponentially across multiple generations due to a combination of epigenetic and environmental factors as the transmission of intergenerational trauma reduces. This concept fits right in with the MAHA agenda, confronting the root causes of chronic disease. While ACEs have not proven to be a predictive tool at an individual level, and there is conversation about how best to move forward at that micro level, at a population level, ACEs have proven to be one of the strongest predictive tools that we have to project a wide range of physical, behavioral, and social health outcomes. We have seen the work done successfully at scale. Earlier, Margaret was talking about the work currently being done in Washington State. I will look at work done in the past in Washington State by a different agency, the work of the Family Policy Council from 1994 to 2011, that has gone on to become known as self-healing communities. Through a combination of community-led, systems-focused, and trauma-informed approaches, the state worked with several dozen communities and counties to support innovative approaches to address multiple outcomes that the state was burdened by. Rather than focusing funding and efforts based solely on outcomes, they focused on the processes that communities were taking to improve outcomes, which reinforced learning loops that enabled improvement over time. As a result of this work, remarkable outcomes were achieved. As you can see on the slide, Cowlitz County realized a 98% reduction in youth suicide and suicide attempts, a 62% reduction in births to teen mothers, which had massive impacts on child welfare system involvement, 43% decrease in infant mortality rates, 47% decrease in high school dropout rates, and 53% decrease in youth violent crime, which had massive impacts on justice system involvement, and all of those outcomes were achieved at the same time. And similar outcomes were achieved by other communities that participated as well, because they were addressing the root cause drivers and moving upstream. As a result of these outcomes, and this is a direct quote from their report, the taxpayer savings from network improved rates from 2002 to 2006 were conservatively estimated at an average of $120 million per year. The cost benefit ratio for this investment is impressive. For every dollar spent, $35 were saved. End quote. The work done by communities to produce these outcomes may surprise you. There was education to empower families to improve outcomes, as has been discussed by many colleagues today. But for communities using a systems lens to address problems, upstream efforts reduced preventable burdens and improved outcomes. One community, for instance, had high rates of criminal behavior, so they organized a turn the lights on event to fix broken street lights, which altered the physical conditions in the community that led to vandalism and other problematic behaviors, and those issues within the community reduced quickly. Another community struggling with high levels of poverty organized to put in a bus stop to increase access to transportation, which enabled residents to get higher paying jobs in addition to a myriad of other benefits, transforming individual family trajectories, as well as increasing the tax base for the community. This work that has become known as self-healing communities is the only work that I know of at scale that has reduced ACE prevalence across a population, which is why the outcomes, both socially and economically, are so profound. While different communities have different populations, needs, resources, and desires, so we cannot have a singular one-size-fits-all approach as we implement this work across a large population, there are common elements, best practices, and shared learning that must inform strategies so that communities are not forced to recreate the wheel. As has been described throughout the day, we know more than enough to get started. Washington State's work, as I briefly described it, ended by focusing the funds and programming from whole community and family well-being to focusing those state efforts and investments just on the youngest children. These ages and work are critical, of course, but we must also recognize that childhood does not exist in a vacuum. Family and community life has massive impacts on children beyond child-specific programming alone, which I hope sounds like an obvious statement, but we must keep this in mind when we are discussing policy, not because there can't or should not be early childhood-specific investments, there absolutely should, but because we must be cognizant of how those investments and programs fit into a comprehensive agenda and broader effort to promote holistic well-being throughout our society and across generations. And that is why the full picture of the decade of the child that we have been discussing all day is so critical. My work, how I am weaving what I've outlined so far, is focused on building a strong social infrastructure through policy and practice, coordinating and aligning federal to state to county to municipality to community efforts to promote well-being, and developing a financing model to sustain and scale investments and return on investments, as Charlie mentioned in the lead-in to me, over time. We call this policy effort at the Change Campaign the full press. Our public systems, as I mentioned before, pay massive sums downstream for the impacts of ACEs and other developmental adversities that we fail to prevent upstream. It harkens back to the parable where a group is fishing on a river and suddenly sees a kid drowning, so they jump in to save him. As they get that kid back to shore, they see another kid and do the same thing, and then another. After doing this enough, one of the fishermen runs upstream and the others yell at him to get back there and help them. You keep saving those kids, he says. I am going to find out why they are falling in to begin with. And while as a society we undoubtedly need to continue to bolster and strengthen treatment and intervention systems, we undoubtedly need to do much more to move upstream to prevent as much harm as possible, which will reduce bottlenecks, improve access to services, improve the services themselves, and transform the ways that our society is able to function. We have, in addition to the work that I mentioned in Washington, seen a state create a sustainable economic model in Maryland, where Maryland created a credit-based methodology to incentivize the prevention of diabetes. So using a synthetic cost curve and estimating the 5-year cost of the state treating diabetes at around $14,500 per case, the state wound up preventing diabetes and paying over $7 million for prevention programs in its first year of 2019. ACE attributable outcomes include but are much broader than just diabetes, as I will get to in a second. And so by reducing ACE prevalence, like what was accomplished in Washington State's program, we would expect to see even greater returns on investment than the impressive returns that Maryland experienced. Let's make these claims about ACEs more concrete. Because of the strong research base and its replicability across studies, population attributable risk factors associated with ACEs that impact our society. Studies have found that 25.5% of cardiovascular disease, 24.3% of cancer, 22.2% of asthma, 55.7% of anxiety, 42.7% of medical treatment for a mental health condition, 28% of lifetime smoking of tobacco, 58% of lifetime suicide attempts, 65% of alcoholism, and 78% of intravenous drug use is attributable to ACE exposure. We know other figures as well, but I use these as examples to spell out my earlier claim that we can significantly reduce negative outcomes across physical, behavioral, and social health that have massive impacts on our society by moving upstream. These numbers begin to illustrate how we can build a financing model as well. By mitigating ACEs that have already been experienced, and by preventing ACEs in current and future generations, we would experience profound cost avoidance in our society moving forward. And while it would take some investment upfront, without a doubt, it would be nowhere close to the returns as indicated by the 35x ROI that the Family Policy Council realized from their work, and that number would likely increase at the generational markers between 20 to 30 years and then 40 to 60 years and so on, when children born into healthier communities and systems start having children of their own, whose own outcomes are likely to continue improving, which would then compound over time until, as with all exponential curves, a plateau phase would reduce the climb of said returns, but that would likely be many, many generations in the future, and at which point the burdens that our systems currently experience would be so fundamentally different that we would have new problems that required new solutions. So using par values, we can estimate cost avoidance generated from improving outcomes, and using a similar financing approach to what the state of Maryland's diabetes methodology illustrated just across a matrix of ACE attributable outcomes, we can capture those costs and share with government partners while also then being able to reinvest that back into the initiatives that are driving cost avoidance in the first place. This is critical because often prevention work fails to sustain and scale because of the wrong pocket problem, where fragmented systems do not share returns from where investment is made to where returns are realized, which often gets in the way of continued investment and the greatest possible social benefit. Building community capacity as a foundational step to then be able to implement any of and over time all of the valuable and necessary efforts to improve child and family outcomes with community champions to increase local buy-in is what we are working to scale. I am currently working primarily with states, and so I will focus mostly on what this looks like at that level and below. But we'll quickly just say that as we scale across states, there is a clear role for the federal government in coordinating and aligning such efforts. I worked with the federal government's interagency task force on trauma-informed care that started during Trump's first administration and saw the promise of moving forward greater federal coordination, and there is certainly an opportunity to continue such efforts. But I currently serve as the director of HEAL PA, which is Pennsylvania's statewide system of trauma-informed care. So I'm going to use Pennsylvania as an example for how we are thinking about operationalizing all that I have been discussing in policy. HEAL PA has existed for several years, and there are a number of local, both county and community, coalitions that have already engaged with this statewide initiative. These coalitions do not yet expand to all 67 counties, and so without that, we are far away from the sub-county penetration to municipal and community levels throughout the state, but we do have a good start. We are working to support these county and community coalitions in a number of ways. First, we are just providing a space for them to convene with each other so that they can learn from and support each other rather than do all of this work on their own in isolation. That is already hard enough, let alone when we consider that so many of them are doing this as volunteers. We can increase efficiency by connecting the network together as a learning community. In addition to connections to each other, we are also supporting the development of strategy as coalitions want. We will not force any coalition to do anything that they do not want. They have control as community-led as part of the secret formula that made family policy councils work so transformative in Washington state, but we are here to support with strategies to help implement the full press at scale locally. For the work of being trauma-informed at a community level, in Pennsylvania, there are two wonderful partners who are supporting different elements of trauma-informed education and implementation. The Neighborhood Resilience Project has created a trauma-informed community development training and framework to support local implementation of trauma-informed efforts, as well as a data collection tool that analyzes community well-being at a hyperlocal level down to the block level to help create a community picture of what needs to be addressed and what efforts are working. Lakeside Global Institute also has a host of trainings across a number of sectors aimed at both parents and professionals to integrate trauma-informed approaches into their daily practices, as well as are developing technology tools to help support targeted questions that emerge. For the work of creating a systems lens, an early partner is the Rural Opportunity Institute from Edgecombe County, North Carolina, who have published the results and impacts of the systems map that they've made with their community. They found the process to engage residents and reduce blame on individuals and turn action toward addressing where systems are broken and failing. And they are an early partner to support coalitions in integrating a similar process to ensure at least parts of the work are upstream. As coalitions get situated with the work they are doing, we are working to engage county governments, and where municipal governments are robust enough, them as well, to collect data and support the economic modeling described above. Counties in Pennsylvania directly administer children and youth services, mental health and intellectual disability services, drug and alcohol programs, juvenile probation and court services, among others. They fund and operate human services infrastructure that touches residents at the most vulnerable moments of their lives, and they absorb those costs when those moments compound across life course trajectories. At a state level, in addition to bringing folks together from across the Commonwealth, we are in conversation with the government around data collection across specific agencies that illustrate where cost avoidance is emerging for the state, and again, sharing with the government while also reinvesting back into the community capacity that is driving that cost avoidance in the first place. There are a ton of agencies that are relevant to this work as ACE prevalence drives systems involvement and costs broadly. The Department of Human Services administers child welfare, cash assistance, Medicaid, and intellectual disability services. The Department of Health oversees public health infrastructure and captures a tremendous amount of data. The Department of Education administers K-12 education funding, alternative and special education funding, and collects student outcome data. The Department of Corrections manages the state prison system, where the connection between developmental adversity and incarceration is among the most well documented in literature. And the Office of Mental Health and Substance Abuse Services administers behavioral health systems where ACE-related costs are concentrated. There are many other agencies as well, but this spells out the point pretty well that we can capture cost avoidance and that we are not asking states necessarily to collect new data, but to look at existing data sources in new ways. So we are creating that infrastructure from the state to the county to the community level and coordinating and aligning efforts to integrate a public system that has for so long been fragmented, which puts additional stress on everyone, especially those with the greatest need. Collecting data at the community, county, and state levels paints a more robust picture of where returns on investment are being generated and what is driving them so we can sustain and scale return on investment over time. Creating interagency coordination at each of those levels to share data and look at it from different angles is critical to ensure we are getting a full picture to allow the strategy to compound as much as possible over time. I outline all of this not just to highlight the work that we are doing, but also to bring an important conversation that this is a real paradigm shift to how we think about policy. At the federal level, a CBO score is typically in the 5 to 10-year window when analyzing the economic impacts of a given policy. The work that has been described throughout today's webinar will have a positive impact in a 5 to 10-year window, but that impact will pale in comparison to the generational impacts of the work. We cannot fix generational problems just with short-term approaches, unless, as I mentioned earlier, those short-term efforts are part of a comprehensive strategy. Short-term investments continue to propel our national debt, which is then used as a reason to not invest further into what would ultimately reduce the debt burden our society is constricted by. NIH has a huge role to play in promoting the research. Again, we already know so much about what works to shift the paradigm of how we invest so that we can strengthen our society as a whole. That is what the Decade of the Child can do, and what I hope it does. It has the potential to transform our society to reach its full potential, which can only be achieved by supporting everyone to reach their full potential. And we know that the best way to do that is with a strong start. We must invest in children, families, and communities in new ways to produce new outcomes. And I hope that we partner on this critical effort moving forward. And with that, I'll turn the floor back over to the architect of it all to close us out. So Denny, it's all yours.
Jesse, I mean this in every sense of the word. Thank you for your brilliance. That was so much to pack in there. I realize the challenges of our time constraints, but it was worth every word, and it will be in our recording in perpetuity. So, and this recording will be shared very broadly, and many, many more people will see it. So thank you all. I am going to just do a very quick, because I really want to get to people's questions. So I'm just going to do very quick. I was going to do a recap, but I think I will truncate a bit and just get to a couple of points that I really want to make. And then I'm going to ask everybody to get on the platform and we'll address questions. So I have these pretty slides, so I have to show them, but like I said, I really just wanted to kind of go through the points. Not everybody who is on now is on this morning. And just for the sake of the recording, I'm just going to go through this very quickly. So just, we began with Christy Bethel's demonstration that current child outcomes are unacceptable and they're costly. This is a figure from Annie E. Casey's Kids Count, which shows the darker the color, the worse the outcomes for children. So, the bottom line is that improving child well-being is a moral and an economic imperative. We know what whole child health means. It emphasizes that health on all fronts emerges from the interaction of all these conditions and more. So that we need to understand that every single experience that a child has makes a difference for a lifetime, for better or for worse. And across decades of research, we know so much. Everybody has established that. The evidence has accumulated that all of these things, the biological, social, environmental, relational foundations of healthy development. We understand that the science is no longer asking whether these factors matter. It has consistently demonstrated that they do. And then Zilli Sloboda presented the framework and the purpose for this webinar because she was the originator of this idea decades ago, right? To really emphasize that the challenge before us is no longer just generating knowledge, it's using the knowledge to transform the systems and the structures and the policies that shape children's lives. And these are the activities that we're engaging in. So we're promoting a pragmatic program of research. We're promoting a child-first, child-focused policy agenda in Congress. We are doing this also at the community and local level, and we are working to increase public awareness so that we can have the public clamor for these policies. Dina Chisholm's main takeaways. This slide is messy. You will be provided with my slides if you want to dig into any of this as well as others. But child health is built on decades of research in development and prevention, and population health and health services and health equity. And she talked about landmark initiatives, as did NIH, that have demonstrated that children's outcomes are shaped by all the things that we've been discussing, not medical care alone, and that we need coordinated multi-sector approaches. And importantly, very importantly, we need community-driven solutions and strategies. And then the Institute directors highlighted their research portfolios very broad in whole child health and well-being, especially NICHD, which obviously, given that they're all about children's health, has played a central role in pediatric research, supporting research very broadly on children's health outcomes and what it takes to improve them. And it was also made clear by NCCIH, NIMH, the National Cancer Institute, and NIDA that have developed complementary perspectives in terms of innovations in whole person health, in innovations across the board, youth mental health, pediatric cancer, substance use prevention, longitudinal brain development research, and so forth. And there was a shared theme across the institutes that advancing research to understand all the various factors that shape children's lives is key to an actionable roadmap towards healthy children. But we also made clear that while we know what to do and we know why, we don't exactly yet know how, that there's a translational gap. And that means that many children do not reap the benefits of the research and the best practices that it generates. So the question then shifts from what works to how do we make it work in any given setting for any given child? And that's what the next set of speakers put this question to perspective about by discussing approaches, that we know are effective, that are cross-sector, that are system-wide, and that develop the infrastructure that's needed to scaffold these approaches so they can be scaled and sustained. And then Ron Prinz talked as a component of that translational pipeline. He highlighted the transformative potential of population-wide parenting and family support systems. And that really exemplified the upstream strategy that we're really honing in on with large returns for health, education, and economic outcomes. And then Tony Biglin very compellingly directed our attention to the research that consistently shows that poverty and discrimination shape development. We know that poverty increases risk across multiple domains. Discrimination harms health and well-being. Opportunity inequality affects lifelong outcomes. Downstream interventions alone are insufficient. And to improve outcomes, we really have to address, as you see in this figure, the upstream conditions that target the fundamental social drivers of health. Then Bill Weick-Zorich operationalized for us how we can and should restructure and integrate public service systems around the sciences of prevention and health promotion rather than crisis response, and the need for cross-sector alignment, as well as policy frameworks that elevate children and provide financial structures for prevention and service delivery, and that can ensure accountability. Margaret Kuklinski then highlighted, I know so much, how to build the community-wide infrastructure necessary to support that whole broad implementation and sustainment of what we know works, so that it isn't occurring on that fragmented and piecemeal basis, which describe the approaches that we've used to date. Charlie Brunner stressed that health improvement requires moving beyond a biomedical focus to a broader coordinated approach that addresses those social drivers of health, scaling the kinds of strategies that we talked about, and particularly through early investment in children and families to improve well-being across the life course and across generations. And then last, but definitely not least, Jesse Kohler provided a very compelling argument for investments in children, pointing out that with nearly $40 trillion in national debt, the United States really must prioritize these strategic high return investments, particularly those that strengthen safe communities and healthy families, because ultimately they will reduce the long-term public system costs and expand future economic productivity and break the cycles of intergenerational trauma so that we have compounding returns over the decades and generations. So we know a lot, Decade of the Child, right? We need to learn more. We need to learn more about policy in particular, which policies can deliver the most measurable benefits, how to move proven solutions into broader use, and how we can institutionalize those returns for lasting benefits across generations. So this agenda builds on repeated calls throughout the webinar for this pragmatic program of research that's capable of producing real-world impact. And I discussed that in my opening remarks in depth, and it was reinforced throughout the webinar. So there's a real need to build on these best practice protocols for implementation, dissemination, scaling, sustainability, community engagement, and policy experimentation, all the while assessing equity and population impact. So we know, programs change individuals and groups, but systems change communities, and policies shape entire populations. So that is a major aim of the Decade of the Child. We really want to reinforce the need to look at policy as one of the most powerful interventions available. And here's just one example of national paid leave and its reduction of child poverty. Substantial and potentially exciting if we can really increase the political and public will here. Here's some questions for this research agenda to address. Again, slides will be provided. And so in short, from insight to responsibility, we want to improve children's lives at scale. We understand what the problems are. We have the tools. We need the awareness. We need this wide-scale implementation and the political and public will. And just to end, I want to just re-mention this congressional briefing that those of you who were on this morning saw. The lead authors of the Launching Lifelong Health Report from the National Academies are hosting on July 21st. And so now we're going to turn to questions, and I will leave this up for a second. Could everybody who has spoken come on your video and audio, and we will take some questions. Okay. Wonderful. Let's see, 20 minutes for questions. Hi, everybody. It's good to see your faces. It's been a long day, and I am so appreciative of everybody who stayed on for this day. I'm going to go through some of the questions in the Q&A. I think they're going to be too much for us to address in 20 minutes, but let's get to a few. So, sorry, I have to read. Is there conceivably a place for tax-advantaged investments directed to enabling the positive outcomes we've talked through here, particularly on proven prevention-based tasks and actions? Tony, do you want to start by addressing that?
Can you hear me?
Yeah. You want to come on
Well,
video?
I'm not sure that this is an answer to this, but what I wanted to
Okay.
mention, just based on what you were saying, is that Values to Action is working on getting policies focused on increasing family income. We've identified communities around the country, a small number of them, that are making progress on doing that. And we're trying to we want to have a conference on that where we get people who are doing this good work, but also people in communities who just want to find out how they could do more. So if you're interested in that, we might collaborate on it. And Denny, uh, they should build a statue to you in Washington, D.C.
Oh. uh, uh-huh. I think there's competition for that, Tony.
I'd
Okay.
make a quick response. I
Yes,
think
please.
that there's interest in, can we do something through accountable care systems, through other types of means, through pay for performance, through other types of activities? Can we provide incentives for people doing things? I think basically we need to provide the resources to go forward in a way that is directed and really does go forward. If we're going to try to use the tax system to do things, the first thing we ought to do with the tax system is get rid of the family tax penalty that exists that fails really to recognize that when you are a parent or become a parent and you have a child or a new child, you have additional expenses and costs with raising that child. And you also have additional responsibilities for caregiving that impacts upon your ability to earn and what you need in terms of further expenses. And our tax code does not recognize those costs. The child tax credit is half the size of what it should be, and it's not refundable. So the whole variety, most families, in a family of four making $55,000 a year, receives no benefit from the child tax credit as it currently exists. So it's only at the upper income levels. I think people should get this because when you have kids, the tax code ought to recognize that. But we need a child tax credit that's, as Tony said, at least that $3,600 fully refundable for young children, $3,000 that we had for 2 years that took half of all kids out of poverty, but really made it possible for families to fulfill their breadwinning and caregiving roles. And I think that kids are important, and we ought to be investing in them and their solutions without thinking that we have to somehow do some type of balancing or incentivizing through some type of tax activity to do so. We ought to just say that these are the most important investments we should be making. And Jess's stuff around the return on investment, this is where dollars should go first, not last in our budgets.
We need to find ways to publicize this that go beyond people such as ourselves. We need thousands of people, which is one of the reasons I think it's important to start working in communities to try to start working on this and build a much larger group of people. And it can be done.
Yeah, there have been quite a number of questions actually about how we advocate. And I think that's really a key point. We all have tools at our disposal, no matter who you are. Some have more tools than others to do advocacy, but we all have tools. We can talk to our representatives, we can write letters, we can vote, we can really represent what your own values and what you think is important to others. You can talk to your neighbors and your family members, right? And then others of us have advocacy tools where we can actually reach Congress and we can have those kinds of exchanges. So everybody has something at their disposal. There are, and we can include that in our resources when we bring the recording to you, that there are platforms where you can learn how to advocate. Anybody can learn how to advocate. And so we can bring that to people in order to, develop a voice, be able to bring your own voices to the table. So I think that's really important for the community to speak for itself. So we're talking as researchers and so on, but we really want to bring your voices to the table. We want you to be able to do that. So advocacy is very important because a lot of folks are concerned about, children not being adequately represented in our policies. Christy, I was just going to ask you a question. You went off video.
Yeah,
Are you
sorry.
there? Okay, good.
I
No,
was
it's
just I
fine.
was typing you a text, so I didn't
Okay.
know if you just see me
Yeah,
looking down.
yeah. That's fine. Philip, our friend, Stegman, has asked what kind of prerequisites will be needed to implement a federal strategy for flourishing, one that embeds a shared developmental framework into the programs, policies, and funding that comes into communities.
Yeah, I mean, that's what we're trying to do is focus on the positive outcomes. And since we recognize so much of the kids who don't have the illnesses that we often study are not thriving, are not flourishing. And many that have the conditions we study they're really on a dual continuum. And so we don't have to get rid of everything bad to promote the positive. And we can do that through systems that we have in place right now, which are, sort of looking soft, but they're really the hard science. And of course, doing that means we have standardized measures and concepts that we can agree to. We've come a long way. We have national outcome measures on flourishing, ACEs, with all kinds of data at the state level that can be replicated locally through all kinds of platforms. So I think that, I read the strategic plans of all the federal agencies under OMB, codified them, all the accountability systems. If you read them, they look like they're pretty aligned with what we're talking about. Or close enough that it could be elevated with an explicit link between them. And I don't think it would be hard to do that, but it would be relationship building, collaboration, just like you do locally. You have to do that federally. So ironically, one by one, maybe probably with the national centers and NIH as well, there's a lot of things you can point to that sound like they're aligned, but they're lacking that shared accountability and feedback loops to see how we're doing and what's working for whom. So I think some of the requirements would be a shared vision, and I think we can get there. Common feedback loops and measures, we're very close to that. A real analysis and careful interweaving of roles for the different components that need to be addressed, which we've talked about, the different components that impact leadership, governance, financing, data sharing, engagement, training, services, all these things. So there's a roadmap we've kind of mapped out for young children and just looking at primary prevention, but the concepts are the same. Much of what Jesse was talking about, these are the components. But the interesting thing is that federal programs really do impact states and then down to local and city. And that is part of what we've been outlining, and also in the Launching Lifelong Health report. We didn't get to put everything in there, but reviewing all the accountability systems that impact what people do on the front lines, like providers of all kinds, and so on and so forth, they're close but no cigar, I don't know where that term ever came from, and I've never used it before, but there you go. So we can do a lot by aligning low-hanging fruit to start to catalyze and free up possibilities. And then, of course, the funding is really a bigger issue of public policy, but we have a lot of money in the system that we're spending not producing outcomes, and we could do a lot just by interweaving those. So that's my statement without talking on and on and on or starting to show you slides.
No, that's great. That's really great.
Mm-hmm.
So a question for Dina. How do you address racism in this discussion? And because you brought up the issue of equity, I thought you might like to speak to that.
I think that, it's important that we recognize that racism has become, in some ways, more of a buzzword than a focus. And, what we have to focus on is how are our systems, how are our behaviors, how are our policies disproportionately damaging some of the children in our community. And when you put it that way, you start to take folks off their guard, start to take people out of their camps to the point where you can have an actual discussion. Because when you start using real words like racism, folks shut down. And they shut down not only what you say, but they shut down your science. So it's really about figuring out how do we frame the same concept in a way that is accessible to folks across the spectrum. How do we address it? We look at every policy, we look at every decision, and we say, does the way we do this impact everybody in the same way? It's a simple question. You can ask it in every quality improvement meeting you have in your hospital. You can ask it in every community meeting. You can ask it in every state legislature meeting. Does what we're doing right now impact everybody the same way? And if the answer is no, then the next question is, are we okay with that? And if the answer to that is no, then we say, what do we do about it? That's the way we have to address racial disparities, racial differences, and all of the isms and all of the discriminatory approaches to what we do is by those simple questions in rooms and asked by people who don't always look like me, because when people like me ask them, there's like, oh yeah, there she goes again. But really having everybody in the room ready to step up and ask those hard questions and demand the hard answers.
Yeah, very good.
I,
Yes.
I brought this up briefly, but this is one area where I think there needs to be a focused investment and work. And we're not going to either improve population health in the way we need to for children or reduce health disparities unless we do something that does a better job of building communities in historically disinvested and poor and segregated neighborhoods. If you take the CDC's social vulnerability index and look at the highest risk areas in the social vulnerability index where 10% of all people live, it's actually where 12% of all children live. And it's where 45% of all African American kids live, and 35% of all Hispanic kids live, and 40% of all Native American kids live. And those communities lack housing, a decent environmental built environment, jobs, and economic opportunity, and they're not safe places. We have to find some way of investing in those, which I think is part community building and working within those communities. And we haven't had something that really has tackled that with children in mind. Since the war on poverty and the establishment of Head Start and some other initiatives. But I think that's a piece of something we just have to do because place does matter, and it matters particularly for kids. That doesn't deal with the fact that a lot of our racial inequities come from institutional, historical, and structural racism and the vestiges of being left behind in the past or held behind in the past. But it's particularly prominent in those areas, and we simply have to make a national commitment to making investments in those communities and neighborhoods.
And we have to find a way to make those investments in a way that allows that community to benefit from it. Because
that's why I said community building with the community, not to the community.
Cleaned up, the new housing comes in, and folks are displaced, and you just scatter the problem rather than fixing it. So it's a very complex set of approaches we have to do to impact, systems that have been in place for a century.
Yeah, we only have 1 minute left, but
Can
I
I-
don't know if you've heard of interest convergence. I think it's an important concept relative to this conversation. If you don't know what it is, please do check it out. But we do have to stop in a minute. I did want to say that a number of people have asked, like, how do you get bipartisan support? How, what does this strategy look like? Is there a framework? The Decade of the Child has a very detailed, multi-page strategic plan, and it's multi-pronged. And it spells out how we think we can make this work, even given some of the challenges that we currently have with focusing on children's health. So it's 5 o'clock. I wish we could just go on and on. No, actually, I'm pretty tired. But
Gonna
this is
say.
I know, right? This has just been remarkable. And I'm telling you, every single speaker was outstanding, just really over the top outstanding. And I just can't thank you all enough.